Hi, good afternoon, everyone. Come on in and make yourselves comfortable. I think a few people are still trickling in. We're all well versed in how tricky parking can be. Welcome to the second annual Valve Disease Awareness Day at the University of Ottawa Heart Institute. Thank you to everyone who has taken the time to join us both in person and online. My name is Elizabeth Murray. I'm the TAVI nurse here at the Heart Institute. Myself, along with my colleague, Haley Emmerson, will be your moderators for today's presentations. So for those of you who may be joining us for the first time, although I do see familiar faces, so welcome back for those of you who came last year. February 22nd, so that's a Saturday this year, that's International Heart Valve Disease Awareness Day. And this was established in 2017. It's an annual campaign where partners such as Heart Valve Voice Canada and the Canadian Cardiovascular Society are hoping to improve awareness, early detection and diagnosis, as well as timely treatment for heart valve disease through the education of Canadians on the importance of something as simple as a stethoscope check, especially for those who are 60 years of age and older.
Thank you, Liz. So prior to beginning the event, we would like to go over our land acknowledgement. The University of Ottawa Heart Institute acknowledges the unceded traditional territory of the Algonquin Anishinaabe and the people of the Algonquin Anishinaabe Nation. We recognize all Indigenous people in the region from all nations across Canada who have also made Ottawa their home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. We dedicate ourselves to moving forward in the spirit of partnership and reconciliation. Together, we take responsibility for the heart health of all people in the region. So here's a quick overview of our schedule for the day. You can see that we have lots of amazing topics and speakers, as well as a few breaks throughout the day to focus on heart valve disease.
So prior to getting started and introducing our first speaker, there's a few housekeeping items. We're going to have two breaks, one scheduled for 4 o'clock and the second break is scheduled at 5:30 where a light supper will be served. Washrooms are located just outside of the auditorium if you turn left. I'll ask that you ensure that the ringer on your phone is turned off or to silent, please. We'll have a brief period of time for questions at the end of most of the presentations, but if we're not able to get to your question, please save it and we will do our best to answer things with the panel discussion. We also have a few prizes, door prizes up for a draw. So if during the break you haven't done so already, fill out your name and place it in the draw box just at the table outside of the door. Along the side of the auditorium, you'll note that there's some information booths for our in-person participants. There's some information with regards to women's heart health and prevention. Our sponsors, Abbott and Edwards, are here as well. There is a TAVI booth and the Heart Institute Foundation. And if you're online, you'll have information about each of these groups in your package that you've received. And we'll just ask that you complete our survey at the end of the day. We appreciate your feedback to continue to have this be an interesting and useful event. And our last housekeeping, we want to say a big thank you to our gracious and generous sponsors, Abbott and Edwards Life Sciences, for helping to make this day a reality.
And now on to the good stuff. So our first speaker today is going to be Dr. David Messika-Zeitoun, who will open our day with the welcome remarks. Dr. Messika-Zeitoun joined the Heart Institute in 2018. He is a cardiologist, researcher, and medical director of the Center for Valvular Heart Disease, the mobile screening program, as well as the valve program at the Heart Institute. Thank you, Dr. Messika.
Thank you, and thanks everyone for joining in person or online. So what we'd like to share with you is some general information on valvular heart disease and present the program of the day. So simple things, valves are the door inside the heart, they direct the flow, and they can dysfunction by malcoapting, not closing well, or not opening well. The three main valvular heart diseases that we see, at least in Canada, are aortic stenosis, mitral regurgitation, and the tricuspid regurgitation. I'm sorry, the last one is not working. But... So it's disease related to age in Canada. We don't see much rheumatic valvular heart disease, and most of the valvular heart disease that we see are linked with age. You see the increased prevalence with age for any valvular heart disease, the mitral valve and the aortic valve as well, with a dramatic increase after 65 years and older. Percentage is around 4% between 65 and 75 and can raise up to 10% after 75 years old. You all know that our population is aging. For now, we have around 7 million of people that are 65 years or older, and we expect that to double in the next 20 to 30 years. So just by aging of the population, we can expect that the number of patients with valvular heart disease will double in the next decade or two. So clearly, valvular heart disease is the next epidemic. So it's a degenerative disease. It's a progressive. And for now, we don't understand very well the pathophysiology, what's causing the valve to dysfunction. And because we don't understand that very well, we don't have any medication. We can have palliative medication like diuretics, but we don't have any medication that can slow down or reverse the progression of the disease. And you can say it's not bad, but only treatment that we have Dr. Al-Atassi here, is to replace or repair the valve. For replacing, we have two types of prosthetic valve, tissue valve, from animals or mechanical valve, and we can repair the valve using the patient's own tissue. And the bad thing is that if you don't, or the good thing, it depends how you see things, if you don't treat the patient with valvular heart disease, mortality is very high. The good thing is that if you treat them and timely, you markedly improve the outcome. So valvular heart disease are little, but we have a way to improve the outcome by fixing the valve. This slide shows you the number of aortic valve replacements performed in France between 2007 and 2019. You see that the number of replacements has doubled in a little bit more than 10 years. It's not due to the marked increase of the disease. It's due to the fact that now we have new way of treating patients. Patients that were denied any intervention 10 years, 15 years ago, we have now a new modality to treat them and with less invasive options. And could be done by the TAVI. You will hear about that by Dr. Al-Atassi. It's also true for the mitral regurgitation and more recently for the tricuspid regurgitation. And we have to be fair with our surgeon colleagues. They have made also a lot of progress. We have new way to treat surgically patients with valvular heart disease, less and less invasive way. You have the minimally invasive up to the robotic approach that we have here at the Heart Institute. So the transcatheter therapy has completely changed the way we are treating patients with valvular heart disease. What is the optimal journey of a patient with valvular heart disease? First, you need to be aware that your patient has a valvular heart disease. So you need to screen and detect a patient with valvular heart disease. Once it's detected, you need to confirm that the patient has a valvular heart disease, and we use the first line as echocardiography. When the patient is diagnosed with valvular heart disease, significant, it needs to be assessed by a cardiologist. The cardiologist will confirm the severity of the valvular heart disease, will assess the consequences, follow the patient, and refer the patient for an intervention when it's timely. And the patient is referred to centers who can offer all kinds of treatment. We have seen surgery, but also transcatheter therapies in a timely way to treat the patient. And when the treatment is done, the story is not finished. We need to continue to follow the patient. Unfortunately, all these steps are not working well in Canada, but also in many other countries. And so what we face with patients with valvular heart disease are underdiagnosed, undertreated, and referred late in the course of the disease. And the impact of that is increased mortality, increased heart failure, increased arrhythmia, increased stroke. We discuss under diagnosis. The first way to diagnose patients with valvular heart disease is a stethoscope. You can hear a murmur. What is a murmur? The murmur is just the auscultation, the translation of the auscultation of the flow crossing a stenotic orifice or a regurgitant valve. So it's the traduction by auscultation of the turbulent flow caused by the valve dysfunction. Unfortunately, in Canada and anywhere in the world, less and less patients benefit from auscultation. In this survey done in Europe, you can see that very few patients get regular auscultation when they see their family physician. It's true for men and it's true for women. There is no sex difference for that. Complexity with valvular heart disease is that you need to think about that before making the diagnosis. Symptoms are very, not vague, but non-specific. Can be shortness of breath, coughing, fainting, chest tightness. Nothing specific to valvular heart disease. So to diagnose valvular heart disease, you need to have a high awareness of that. We have campaign for a lot of things. We have campaign for breast cancer, stroke, heart attack, but very few, or almost zero, for valvular heart disease, and that's why we are here today. Under treatment, this study was done by Mayo Clinic. A little bit old, but I think the findings are still valid. All patients had access to care. All patients had an echo done at Mayo Clinic. They have a diagnosis with severe mitral regurgitation. And even at Mayo Clinic in Rochester, they have a rate of patients referred for an intervention despite a class 1 indication of only 15%. So all patients have been diagnosed, they have access to care. Despite that, 15% get the intervention they need. And the impact of valvular heart disease is huge. Everybody likes money. When you talk to policymakers, you need to talk about dollars. And we did this calculation for one of the studies we have done in France. The cost for mitral regurgitation in a year for death and dollars is the same as breast cancer. So we need to promote auscultation to detect patients with valvular heart disease. And the first step, again, is stethoscope. How we can promote that? It has to come from the physician, but it has to come from patient as well. Each time they are seeing their family physician, they need to ask for auscultation. You cannot have a clinical visit without having your blood pressure checked, your other risk factors, and not having auscultation of your lungs and your heart. It should be part of the basic package. To address some of this issue, we have developed this mobile screening program. Sandra will present our preliminary results. They're not preliminary anymore. We have screened almost 2,500. When a murmur is detected, you need to have an echocardiogram to assess, to confirm the diagnosis, having assessment of the severity and the consequences. And we have one of the sonographer, which will present the basic of echocardiography, what you should understand when you have an echo report. We need to increase capacity. I show you the different actors. You have the family physician, the cardiologist, the echocardiogram. You need to have referral pathways, and you need to have hospitals. Unfortunately, the capacity of all these actors is not good. We all know the crisis for family physician, but the same for cardiologists. We have one of the lowest rates of physician per capita in the world. Echocardiography and access to echo is relatively difficult across the country. CCS, Canadian Cardiovascular Society, and the Canadian Society of Echo is organizing currently a survey to have a better understanding of what are the waiting time to get an echocardiography in Canada. And it's a huge inequity across Canada. And we need to increase the capacity in hospitals. We need to increase the number of beds. We need to be capable of performing more intervention and more timely intervention, which is critical to improve outcomes. In this paper, we describe how we should organize this pathway. And I think it's very important to understand that we can always increase the procedural success and decrease the mortality of an intervention. But if you want to have a huge impact in terms of public health, what we should do is work on the whole process, from detection, diagnosis, follow-up, and timely intervention. If you don't work on all these steps, you will spend a lot of dollars but not improve the outcome. So Canada is aging, we know that, and heart valve disease is going to be the next epidemic for the next 10 to 20 years. It will markedly increase the economic burden, but also the burden on hospitals with the number of interventions that we will need to be done. 10% of patients more than, and part of people more than 75 are deemed to have valvular heart disease. The good thing with valvular heart disease, of course, it's serious, but if you do timely diagnosis and timely treatment, you can restore the life expectancy of someone same age. So valvular heart disease are underdiagnosed, undertreated, and referred late in the course of the disease, but doesn't have to be that way. So there is a critical need now to improve the full process and improve the care of Canadian patients with valvular heart disease. The good news is that Liz mentioned Heart Valve Disease Day. With the Canadian Cardiovascular Society and the working group, we have worked with one of the MPP, Messika-Zeitoun, and February 22nd now has been proclaimed a Heart Valve Disease Awareness Day across Canada, across Ontario, I'm sorry. And I stop here. Thank you for your attention.
Thanks, Dr. Messika. So Dr. Al-Atassi is going to be our next speaker. He has been a staff cardiac surgeon here at the Heart Institute since 2017, and he's here to discuss the transcatheter aortic valve implant procedure with us. So he is our surgical lead for the TAVI program at the Heart Institute, and he has provided this procedure to hundreds, if not thousands of patients over the years. In addition to that, he's helping to promote streamlining of the TAVI procedure at other hospitals across Canada. So welcome, Dr. Al-Atassi.
Thank you, Liz, for this kind introduction. First I want to say that, we present a lot at conferences to many different audiences, and probably this is the most important audience because everything we do in this building is really for you, and so it is truly an honor, and it's the most important presentation that I can give. So thanks for coming, and hopefully this will be informative. I was told I was a little overzealous in terms of the amount of slides, so I'll try to go a little quick. I know Dr. Messika has presented some of the slides probably that I'll go over. So let's get started. So the objectives is to learn about the aortic valve and the aortic valve disease, how to fix, what are the indications to fix a defective valve, different options of fixing the valve, with the focus, of course, on TAVI, which is the topic of this presentation, some of the workup and investigations you can expect to get a TAVI procedure, what the TAVI procedure is all about, and then some of the outcomes. So we looked at this. My analogy is always whenever I see a patient, it's like a house with different rooms and doors between the rooms. And so if the doors are not opening well or not closing to cover the gap, then you have a problem. Things can't go through that. And so we have 4 valves, of which we'll focus on the aortic valve today. And on the left side, which is where the aortic valve is, usually there's oxygenated blood comes from the lungs, and then the pump, which is the heart, gets the blood through that aortic valve. So the door opens and it goes to the rest of your body so that oxygen gets to every organ. So this is a cross-section of the heart, again, showing that the aortic valve is really at the heart of the heart because it's at the center between all the different valves. And so it really is in a kind of a critical area of the heart. Again, very busy slide here, but really just to note that if you split open the aortic valve and the heart, there are many important structures around it. So there are the coronary arteries. I don't know if we have a clicker, but you can see my, I can't really see it very well. So there are 2, LM and RC are the coronary arteries. There's also that yellow structure, which is the conduction system, the electrical wiring of the heart passes really close to the aortic valve. And so whenever we're talking about any procedure for the aortic valve, we have to think about all those important structures around it, and we may affect them during the procedure. So as Dr. Messika said, 2 ways that valves can't fix is if they can't open very well. We call that blocked valve or stenosis, so aortic stenosis in this case, and a leaky valve or regurgitation, and aortic regurgitation in this case, if the valve doesn't close very well, so the door doesn't cover the full gap of the frame, basically, of the door. So here live pictures really of a normal valve right on the left showing very thin leaflets. That's how they should look like, because they open freely and they close to cover the full gap. And then with age, we get calcification. Just like, again, in a house, tubing, you buy the new house, there's no plumbing issues. Eventually, there's calcium that gets deposited. Well, it's the same thing for the aortic valve. And calcium is hard, so then the leaflets are not as thin and they don't open as well, and that's when it blocks. Similarly, you may have rheumatic valve or sometimes other reasons where the leaflets get thickened. So it's not just calcification, but it's the same outcome where it's not opening very well. We saw this, it affects a lot of patients, especially over 75, but we're seeing more and more of the disease. Some of the risk factors, so age, we talked about that, sometimes congenital heart disease, history of infections of the heart or valves, diabetes, cholesterol, hypertension, some of the very common things we see in a lot of patients. Chronic kidney disease is an important one, and any radiation therapy to the chest, especially for cancers, especially in the past where it was radiating the whole chest. And some of the symptoms that we talked about could sometimes be confused with many other diseases. So it's very important to have that high suspicion and at least keep in the back of our minds that there is valve disease that can cause some of those symptoms: fatigue, shortness of breath, chest pain, dizziness, or passing out. Those tend to be the most common ones that we see in patients. Difficulty lying flat because the patient is short of breath, ankle swelling. So, always keep in mind if you have those symptoms that valvular heart disease could be the culprit. So without going into too much detail there, but whenever there's a blockage of the aortic valve, what happens is the heart has to work harder in order to get blood through this narrow opening. And just like going to the gym, basically the heart now is working hard, working at 110%. Every single beat, even while you're asleep. And eventually what happens is this muscle gets thickened. And maybe it's a good thing if we exercise and get our muscles thickened, but for the heart, it's not a good thing. So the heart doesn't like to be thick because it's not efficient in using the oxygen. And that's why it causes a lot of the problems, like chest pain, for example. And if blood is not moving forward, then it starts backing up into the other chambers. You can see this enlarged left atrium. This tends to cause now rhythm problems. And even if it backs up beyond that, it goes back into the lungs. And when we talk about water in the lungs, it's really a plumbing issue. Things are just backing up into the lungs and we feel short of breath. So most common question I get from patients: what happens if I do nothing, doc? Do I really need to fix this? And this is what we call the natural history of the disease, because that's it's important to know what happens if we don't fix it. And over decades, we've found that medications does not alter the natural history. The only thing is fixing the valve. So if we don't do anything, invariably it is a lethal disease. And depending on what the symptoms are, somewhere between 1 to 2 and 5 years is when patients, will make it past that because of the aortic stenosis. Then I get a question, well, I have aortic stenosis, not severe enough. Why don't you just fix it now? And anything we do in medicine and surgery, it's about risk benefits. So if the risk of doing nothing is here and the risk of the procedure is there, then there's no point in doing something right now. At some point, the guidelines would look at the risk when you start to have severe valve problems and symptoms and certain things that we look at, where if we do nothing becomes quite high risk. And doing the procedure, well, it's the same risk. Well, now it makes sense. So there's some point the risk of leaving it becomes higher than doing a procedure. There's never zero risk. And that's when an indication to do something is warranted from our point of view. So the guidelines, we're not going to go in detail about everything there, but there are some sort of big themes that we talk about. If someone is symptomatic and they have that severe valve problem, if they're asymptomatic and it's a very severe blockage, then that's another reason, because we worry about it completely closing off and then there's no blood going to anywhere in the body. Asymptomatic, moderate to severe, but you're going for heart surgery anyways to get something done, well, it may make sense to replace it at the same time. And asymptomatic but severe valve problem, and the heart is starting to weaken because it's working really hard, it's thickened, and it's working at 110%. So those are kind of the general themes. Of course, there are some more details that we look at. Of course, we want to make sure that the symptoms, it makes sense that it's coming from the aortic valve because some other diseases cause these symptoms, and that the life expectancy, usually that there's a good prognosis and there are not other medical problems that are limiting life. So what are the options? We talked about, surgery, Dr. Messika-Zeitoun, which I think there's another lecture on that. And of course, there's TAVI procedure, which has really revolutionized the way we treat aortic stenosis. It's less invasive. We'll talk about the procedure in detail. The fundamental difference is, again, this door and frame analogy. Is surgery, we remove the door completely, we clean the frame from all this calcification, and we put a brand new door that opens freely. For a TAVI, that's why it's called TAVI in Canada. It's transcatheter aortic valve implantation. In the States, they still like to call it a TAVR, which is a replacement. It's not technically a replacement because you're putting a valve inside your native valve. So the analogy of the door, you're just pushing the door to the wall, it's pushing it aside, and you're putting a second door that opens freely. And we do this with a balloon that pushes your valve to the side, and then we implant the new valve in the middle. So again, just how do we decide TAVI or surgery? There are guidelines, American and European ones. We can talk about it. General themes, if someone is quite young, less than 65 years old, or has greater than 20-year life expectancy, surgery is still recommended. Someone over 80 years old or has less than 10-year life expectancy, we usually veer towards the TAVI procedure, and anywhere in between 65 to 80 is usually quite a lengthy discussion if they can go for either cases with the patient, with a multidisciplinary team. The European guidelines sort of took a 75-year-old as the cutoff, and again, it's guidelines, so a lot of times there are nuances that we need to discuss, but any patient less than 75 years old and are low risk for surgery, usually we go for surgery. Over 75 or high risk of surgery or unsuitable for surgery, go for TAVI. Of course, it's a little bit more complicated than that, and we don't have to go through all those factors, but this is what we look at our multidisciplinary team. Many factors make it more favorable to go to a TAVI procedure. Others make it more favorable to do a surgery. And so we have these discussions. Sometimes it's smack in the middle, so we have to really have quite lengthy discussions, sometimes multiple consultations, which could be frustrating for patients, but really ultimately we're trying to figure out what is the best strategy for the patient and for an ultimate best outcome. So what am I thinking when I see a patient with aortic stenosis? You want to have, a patient-centered approach. So we have a discussion with you, good valve performance, excellent short-term outcomes, and an appropriate cumulative risk. And that means if you ever have to come back, what's the best strategy now that sets it up for a better procedure in the future? And that's where those discussions come in place. So workup and investigations for TAVI. What do you expect when you come in and you're already sort of decided that you may get a TAVI, or it's on the list of things that you may receive? These are the lists. We'll go over each one. You get an echocardiogram, a CT scan, an electrocardiogram, sometimes a coronary angiogram. You consult with an operator, either a cardiologist or a surgeon, and then we have a multidisciplinary team that rounds every single week. We discuss about 20 to 25 patients. Liz runs the show, basically. And the beauty, this is probably the nicest hour of the week that I'm involved in, not just the procedure, but really around the table, experts, many brains, many eyes looking at the images, and really everyone discussing what is the best thing for the patient. So it's really a quite fascinating hour that we have every week, sometimes a little bit more than an hour. So an echocardiogram basically looks at, we'll have a dedicated lecture on this, but looks at how tiny is that opening? Is it getting really small? And is it severe now? We look at that turbulence of the flow and basically how severe is that blockage to quantify that. Then we look at a CT scan, which is essential for a TAVI procedure. This is really the roadmap for our procedure. We look at the vessels where we're going to put the tube, and that valve has to pass through that vessel. So is there adequate size vessel, not a lot of calcifications? Then we look at the size of that frame, because we have to basically open a package that has different sets of doors that the companies make, and depends on your frame, then we choose the right door size. And the CT scan gives us this basically detail. We also look at the anatomy, as we looked earlier on. Are things too close that we may injure them and cause harm, and therefore maybe it's not suitable for the patient? So that's what a CT scan does. We also will get information on your coronary. Coronaries are those vessels that if they block, cause a heart attack. So we may have adequate information from a CT scan and tells us your arteries are fine, we don't need anything else. If they're not, then we'll take a look at the coronary angiogram. An electrocardiogram looks at your electricity of the heart. Sometimes you may already have some disease in the electrical wires, and we have a risk of injuring the electrical wires with a TAVI procedure, but that risk is small, although if you have disease in your electrical wires, that may make the risk of needing a permanent pacemaker a lot higher. Coronary angiogram, so that's again, if there are some important blockages, if there are several of them, and the only way to fix it is through bypass surgery, that may already sway the discussion, even though TAVI is feasible, but maybe it's not the best way. Maybe we should have bypass surgery as well as a valve replacement at the same time to fix both problems. If it's a single blockage that's easily fixed with a stent, then maybe we're going to do a stent and a TAVI procedure. So again, a lot of those discussions depend on what we see on those tests. Then we have a consult with the operator, and then we have the multidisciplinary rounds thereafter that week to discuss what is the best outcome. And again, that's the beauty of it, is that you have so many people around the table to discuss what's the best strategy for you. Again, a little bit busy slide, but I'd say probably we've already seen something along that. This is sort of the journey of the patient going in. You meet a lot of different people, from echocardiographers to the cardiologist to the surgeon, nurses. One of the other important things down in that blue box just above the two circles there is you may meet also research nurses. A lot of what made TAVI become what it is today was through research and trials. And so it's very important to keep in mind that when you're approached for that, you know, being part of those trials is probably going to benefit also the next patient that comes in, and you're benefiting from the patients who have agreed to be part of trials in the past, and that's where this is coming from. And then, you know, we decide which way. Do you need a surgery, TAVI, or sometimes medical therapy? There is no need to operate at the moment because the valve is not severely defective. So let's talk about the TAVI procedure. Just a little history before that. It started actually quite early on in the 1960s, where scientists tried to put valves on catheters, and initially it was animal models through a dog, and then it became a pig in the 1980s. And finally, we got to the human in 2002 with the first TAVI procedure in France by Dr. Cribier. And since then, it's gone through remarkable transformation with many iterations of those valves. The technique has improved, the valves have improved to what it is today. So in terms of access, how do we get this valve to reach without doing big incisions like open heart surgery? Well, we have to have a large enough vessel usually where we put a tube, and through the tube, that valve and the balloon passes through. 95% of the time it is through the groins, so no need for incisions, just a poke in the artery, and we're able to go up through that aorta into the aortic valve to perform the procedure. But 5% of the time, there's disease there. Same kind of calcification happening in the vessels, and we're not able to do that. And therefore, we look at other vessels that we can approach. So there's one that goes to the arm, the axillary artery. There's one in the neck, carotid artery. We can also do between the rib incisions and either enter the heart itself directly. It's not a big open heart surgery, but it's still now an incision, sort of an in-between open heart surgery and TAVI procedure. But those are some of the alternative access, we call, ways of doing the TAVI procedure. This is the most common valve we use, and most common valve used, I would say, in North America and Europe. It is a balloon expandable valve, so it's mounted on a catheter. You can see that catheter can be moved around, so it navigates the tortuosity and curvature of your vessels. And then what happens is there's a wire that goes across that tiny opening of the valve. Then we thread this catheter in the valve through the aortic valve, and that will expand and basically deploy the valve while pushing the native aortic valve with a calcium to the side. It is made of a stent, a metal stent, as you can see there, as well as a skirt that prevents leakage around the valve. And then the actual valve leaflets are made of animal tissue that are mounted in the middle and sewn like there. And so they close and open. They mimic what you would be born with naturally. This is what it would look at the end of a valve deployment. So you could see there the coronary arteries here, that little opening in the aorta is far away from the valve. There are no structures injured, it's sitting right in the middle. It hangs on by the calcium, so the friction with the calcium around. So that's why it doesn't move and stays in place. And that skirt prevents blood leaking around this deployed valve back into the heart. These are some of the other valves that are used. These do not use a balloon, but rather they sort of flower up and they have memory in its open form. And so once we are in the right position, we sort of let them go and flower out, and they take position due to the pushing out force that they have occurring in them. So the procedure itself is less. Now, this is actually not very accurate because you see this patient is intubated. The patients usually will get just a little bit of a cocktail of medications to make them feel comfortable. It's less than an hour. It's now probably half an hour, the procedural part of doing the TAVI. So it is a short procedure, not very invasive. You know, again, just to go over some of the risks, patients want to know, well, what are the risks of this procedure? And really it depends on the patient's other medical problems, their presentation, the anatomy. But in general, for all comers, it is quite a successful procedure with low risk in the sense that the biggest things, death, is less than 1%, stroke is less than 1%, and heart attack is less than 1%. However, you know, we may need to place a permanent pacemaker afterwards, which we spoke about because of the electrical system. It's about 5%. Injury to the vessels where we go through, most of the time we can seal them without needing any incisions, but occasionally the sealing doesn't work very well, and we may need to do an incision to fix the artery. It does stress the kidneys in less than 5% of the time because of the dye that we give. And bleeding around the heart or from access artery is about less than 5%. We do have this discussion, which sometimes can be disconcerting for patients, but it is important to have before the procedure. If a major complication should happen, quite rare, much less than 1%, I put less than 1% here, but a lot less than 1%. If there's major bleeding around the heart or there's a tear as this calcium and valve is pushed to the side, or that door, imagine a piece of rock on the door, you swing it against the wall, well, that rock is going to go through the wall. And so sometimes we say we're not going to do TAVI, but occasionally you may not be able to predict 100% of the time. Things may happen. But it's important to have the discussion. Would you want us to do a big open, incision, open heart surgery for a life-saving procedure in this rare occasion? Sometimes we think we cannot fix it or it is really futile, but at times we need to know whether that is something within the patient's wishes. So after the procedure, you stay on the bed for 4 hours, make sure there's no bleeding from the groin arteries. You then get up to the chair and walk, get some blood work, chest x-ray, electrocardiogram, and then we get another echocardiogram to make sure that what we did is working. Most patients are leaving next morning. Some leave now the same day, and we're going to see more of that happening. Occasionally may need to stay an extra 1 to 2 days if there's a pacemaker that's required, if the patient has been admitted for a while before and have been getting weaker while in hospital, or if they have a lot of medical problems. We usually have a follow-up in about 6 weeks with another echocardiogram to make one last check, everything is fine, and then continue following with your regular doctor or cardiologist, depending on where you came from. So long-term outcomes, we're starting to have now 10-year data showing that the valves are working as well as the surgical valves. We do see that in about 10% by 10 years, 10% of the valves, they do fail, but 90% are still working quite well. So some of the potential long-term complications is with any valve, you may have valve infections, and you may have also blood clots that form on the valve. So although we only send patients with aspirin, in about 10% or less, they may get some blood clots, and we may see changes on the echocardiogram down the line, which may require more blood thinners, which is not the usual, but that may happen at times. These are some of the, infection of the valves that are going to actually eat through the valve. Unfortunately, infections usually mean if it doesn't get treated easily, that it may require open heart surgery at that point. That's why we make sure that if you're going to have another procedure, you get antibiotics, especially major procedures and dental procedures, you get antibiotics so there's no infection of the valve after this goes into the patient, because it's a prosthetic device. It doesn't have its own blood vessels, so antibiotics are tough to penetrate and treat an infection. And of course, there's blood clots as well. Occasionally, we may need to do surgery as well there. So this thing called lifetime management of aortic stenosis is a common thing we're talking about these days. Is as we do these procedures in younger and younger patients, we have to think about what are the other procedures that may be required in your lifetime. And so there's different permutations. You know, do we start with a TAVI procedure? Can we do another TAVI in the future? Is it a TAVI and then we have to remove it surgically down the line if a patient is quite young? Do we start with surgery and then do a TAVI? So these are some of the things that now part of the discussions in the multidisciplinary rounds, but also part of the discussion with you. What is the optimal strategy and permutation that we're going to apply in your case? You know, removing TAVI, a lot of times we hear that, well, just remove it the second time around. It has, because we're just learning about it now, and we're starting to see some patients may come back and need a TAVI removed. It is associated with quite a bit of mortality and morbidity. So far, it's sort of in the 10 to 15% range. But as we learn more, that may come down with time. In terms of doing a TAVI inside a TAVI in the future, again, this may be feasible, but we see here in some simulation models and looking at CT scans afterwards, maybe up to 40% of patients may not be eligible to it because those coronary arteries might be too close. And if we put a second valve, we may affect the way the blood flows into those coronary arteries. So it is not always that we are able to predict 100% of the time whether you're going to get another TAVI in the future. We have certain predictors that would tell us more likely, yes, you can receive another one or not, but it's not always foolproof. So we need to have a CT scan to be able to evaluate that. We also have this Russian doll analogy. So again, we're opening the size of a door that fits the frame. And so occasionally you might have a small frame. And so we're opening a small valve. This may mean we don't have as much real estate in the future because we can't squeeze in another valve within this valve. And so that limits the option the second time. And then we have to talk about, you know, is TAVI the better option? Or would we do surgery and try to enlarge the frame a little bit? So that takes a little bit more work, more surgery, but we do it. And so we make the frame a little bit bigger in order to accommodate a larger valve, setting you up for a future valve-in-valve through the groin. There are also now technologies coming up, still being validated, looking at simulation and trying to picture what that valve looks like once it's implanted specifically in that patient so that we're able to predict what will happen and what can we do in the future as well. So a little, you know, a word about our TAVI program. You know, we're receiving about 700 to 800 referrals a year. Liz really gets these and sifts through them, and then we discuss them. 450 TAVIs is what we're at about per year right now. This is going to grow more and more given what Dr. Messika-Zeitoun has showed us. Again, 95% of the time we can do it through the groin, but occasionally we can't. Most patients are leaving the next day. The outcomes are similar to what I presented earlier. And the wait list is among the shortest, I would say, in the country. We're about 8 to 10 weeks now in terms of waiting for a TAVI procedure. So what matters to patients? What are the FAQs that I get? Do I truly need something done? We talked about that. Does it need to be done now? Do I need other procedures before and after? We talked about stenting or the pacemaker after the procedure. Sometimes that is required. Will I survive the procedure? How long will I live after? Again, we addressed that. Stroke, will I get a stroke? Quite small risk of that, but there is a chance. Will I feel better? Will I do things I love? Will I have limitations after? Once we fix the aortic valve, if there's no other limitations or comorbidities that are limiting you in terms of shortness of breath or other things, then you should be able to do all those things. Valve performance, does the valve work well? As far as we know now, up to 10 years, we have good data that these valves are working quite well. Occasionally in some patients who are unlucky or have other, you know, kidney disease or things like that, they may come back with a valve that's deteriorating. And that's the valve durability part. We don't know yet when all those valves will come back being defective. We know in the surgical world, animal valves, depending on the age of the patient, but patients over 65, 70 will have somewhere between 10 and 15 years before they come back for another valve procedure. And that's on average, so some are more, some are less. And that's it. Thank you very much. Or questions now or after? Okay. There's a panel discussion at the end, so we could also.
Hi. Say human heart instead of an animal.
So in fact, there was this excitement about using, these are called homografts because homo comes from Homo sapiens, humans, and cadavers, basically. So there are valves that we use sometimes in infections. In the past, surgeons and patients got very excited about using those cadaveric valves in patients. They work. However, we have found that the way they degenerate, they become quite calcified, and they also limit that second time procedure. I would say it's slightly more complex. First of all, it's a surgical procedure, so it's open heart surgery, not through a TAVI. And the second thing is it is a little bit more complicated procedurally than just doing an aortic valve replacement using those tissue valves. But it is doable, and sometimes in infections we might use those homografts. We do find that they calcify, and when they come back, they're harder to do a TAVI procedure as a valve-in-valve, and also surgically they're harder to go back in because they get rock solid like that. And so it does complicate the second time around. It's also I would say slightly more complicated in terms of putting it in the first time around, and there's no TAVI option of a human valve at the moment.
I think we'll save the other questions. So thank you, Dr. Al-Atassi.
Thanks.
Thank you again, Dr. Al-Atassi. That was a fantastic and very informative discussion about the TAVI procedure. So our next speaker is Samantha Kolupanowicz, who will discuss echocardiogram 101. Sam is a registered diagnostic cardiac sonographer. She is a team member for the mobile screening program and has also worked as an instructor at Algonquin College for the sonography program. Welcome, Sam.
Hi, and welcome to our Heart Valve Disease Awareness Day. Again, my name is Sam. I'm a sonographer, so I'm going to take you through sort of what an echo will show you, what we learn from it, and how it's useful to all our cardiologists. So on an echo, we want to know, what are we going to learn from this echo? So with this, we see the chambers of the heart. So we have 4 chambers of the heart, 2 that pump for us and 2 that fill. So we have the ventricles that pump and the atria that fill there. And we've got our 4 main valves. So the purpose of the valves is to allow the blood to move forward through the heart and prevent it from moving backwards. So the problems that can occur with that is if we have any sort of issues that are preventing the blood from moving forward, so like the aortic stenosis that Dr. Al-Atassi spoke about, and then also if the valve is very leaky. So if things are causing things to move backwards, and again, that can be a number of different things that cause that. So what as sonographers are we looking for? Well, we're taught to know what normal is. So that helps us figure out, okay, something just doesn't look quite right. And then that sort of draws our attention to that. So we use color, Doppler, and Doppler. And you might have heard those words used when you're watching the weather, that kind of thing. So it's the colors that we use when we're doing our exam, if you've ever seen one done or looked at the screen. And it allows us to figure out what is happening. And again, we know what is normal blood flow through the heart. So we're looking for anything that represents abnormal, it's a little chaotic in the color, that's what we're looking for when we're doing these. And then with regular Doppler, what we're able to do is test the pressure gradients at different points in the heart. And again, that'll give us much more information as to what exactly is going on, because if we just look at a picture of the heart, everything is black or white, and we don't get a very good idea of that. But if you've ever had an echo and you hear the noises that go on during that, that's when we're checking out the pressures and seeing what exactly is happening with the blood flow in the heart. So how does an echo work? Well, we use high frequency sound waves, and those are sent out from our camera, our probe, our transducer. All those words are interchangeable there. So when we put the transducer down on the skin, it emits these high frequencies into the body, and then they reflect off of what we're looking for. So sometimes if we're moving around a lot, we're trying to, you know, find that perfect spot where the reflection is coming back to our camera, and then we get our nice, beautiful image, or hopefully our nice, beautiful image on our computer screen or on the screen of the machine. So we have different types of transducers that we use, and it's all based on the frequency that's omitted. So the higher the frequency, the better the resolution. So the clearer the picture is that we're going to get. We're always aiming to get the clearest, best picture that we can, because that gives the best information. So sometimes we'll manipulate the machine to assist us with that. But we always want to have a trade-off. We want to see it as best we can, and sometimes we have to give up on the best image we can get just to be able to see some things. Color Doppler, as I mentioned, it helps us figure out what's going on exactly with the valves, and it tells us the direction of the blood flow, because otherwise it's just black. So something could seem like it's all okay and doing fine, but we throw some color on and it's not. It's different than what we've thought. And then, like I mentioned, with the Doppler, that's when we're going to be checking the pressures and everything moving through the heart. So there's lots of different causes for why you might have a leaky valve or a regurgitant valve or a stenosis valve. So it's something you can be born with. It's something that can develop over time. And then we have varying degrees of the disease. And this is all something that we're able to get a fairly good indication on, if not a great indication of, with our echoes. It allows us to see if the anatomy is sort of damaged and that kind of thing, and then the color will help us, you know, figure out exactly what's going on. So the role of echo. So with we want to identify exactly what, oh, no, I lost my, sorry. Oh, anyway, okay. I'm messing around here, sorry. So we want to identify exactly what's causing the problem. And then that, again, draws us to where we're looking. And that works for regurgitation or stenosis. So if something looks like it's really narrowed, then we're obviously thinking that we're going to see some sort of issue with. We want to classify it. So with our different Doppler, we're able to figure out the severity. So if it's color, we're seeing exactly where is this color going, how far is it traveling, that kind of thing. Is there lots of it, a little bit? And then that helps us to classify and quantify the disease. And then a big role of what echo does is comparing it. So if somebody's had a previous study with us before and we're monitoring them, then that really helps us figure out, you know, 6 months ago, how did it look? If it's looking very different now, then, you know, this patient might need more intervention. If it's looking pretty much the same, then they'll probably just continue on with what's going on. And we're always there to be monitoring, because as was mentioned before, we sort of want to sit and wait before we jump to surgery or anything like that, because sometimes you can make things worse. So the consequences of valve disease. So there's lots of different things that can happen to the heart. And the way I like to sort of explain it is the heart is really good at compensating until it's not. So it's going to maybe do nothing originally, and then maybe we're going to see, you know, those muscles of the heart getting thicker when we've got stenosis, because now the heart is having to work harder. And then long term, over time, when the heart is working so hard, it's gotten sort of as thick as it can, then it's going to start to get bigger. And these are all things that we're going to see on the echo, especially if we have, you know, lots of visits from these patients, lots of echo at our disposal. So with regurgitation, what can happen is obviously nothing. If it's a little bit, as it's progressing, we're going to see some minor enlargement, and then eventually it's going to enlarge, and then we're going to get pressure increases as well, because it's like a balloon. So it's going to get sort of as big as it can, and then, you know, it just can't compensate anymore. So these are all things that we look for when we're performing our exams. So this slide here, it's just showing, we use different language to describe the changes of the heart. So, you know, you've got your normal geometry. Everything is based on body surface area. So we're always, you know, if we have a large individual, a petite individual, all our calculations and everything are based on that. But there are certain numbers that we look to say, okay, nope, that those muscles are a little bit thick, or that heart is a little bit large, and especially in relation to the person that that it's affecting. So yeah, we have different ways of just describing what occurrences have happened. So I'm just going to show you a few videos here now, and just sort of normal, abnormal, that kind of thing. So this here, everything is sort of looking, you know, relatively, the right side should be smaller, the left side should be larger. It all looks pretty good. And then in a heart where there's more of an issue, we've got much larger atria there and ventricles, and they're not squeezing as well. So again, this is something, you know, that we're looking for. Does it look normal or does it not? And then if it's not, we're investigating to figure out, okay, what exactly is the cause of this, and why is this happening? So this one here, this would be a normal or relatively normal aortic valve. It's opening well. We see that. So we'll investigate it a little bit. We always have certain images that we always take on exams. And then when we're noticing something is a little bit off, then we're going to take more images, or our protocol is to do a more extensive investigation of what's going on here. So this one here is a severely stenosed valve. So to an untrained eye, it still looks quite different. So we've got a lot of calcium on there that's preventing the valve from opening up the same way that this nice normal one did. So the benefits of color. So as we can see on this one, again, we see that there's some calcium on it. You know, it looks not terrible, but not great. And then when we put color on, then we're able to see, okay, so not only is this valve a little bit narrowed now, we're also having some regurgitation as well. So depending on the valve and what is occurring, that's going to change what can be done for the patient. So it's really important to not only just focus on the one problem that might be happening, but taking a look at everything else as well. So with this one here, I wanted to show sort of the difference of so this is a bioprosthetic valve here. So this would be taken from either a cow or a pig. And then this one here is a mechanical one. So they look very different on echo. So again, something that we're looking for. We know what to investigate. Oftentimes some people come to us, we don't really know their history, that kind of thing. So it's important for us to know what different repairs and replacements and that kind of thing look like, so that we can investigate it properly. And then this here, so when we're hearing the noises, these are the types of tracings or that kind of thing that we get. So we get a graph, and the graph can be very useful because not only does it give us how fast the blood is flowing through, so we know what is normal, what is abnormal, so that we can figure out, you know, how much is narrowing. But it's also really important when we're doing color as well. So when we put our cursor right through the color jet, is it very dark, you know, or sorry, bright white here, or is it not? And then that helps us again to sort of classify it to say, okay, is it quite severe and we're not seeing it on color? Because sometimes because of the angles and everything that we're working with it, we can't see everything, but we use sort of all of our tools in the toolbox to get an idea of exactly what's going on. And that's that.
Excellent. Thank you, Sam, for a great presentation. So now we're going to have a quick break for about 10 minutes, and we'll reconvene at 10 after 4. There are booths on display if you want to have a walk around and look at what information is there. And if you haven't yet, we also have a draw for our house participants. There is a draw box at the back of the room if you want to fill that out for the chance of a prize. We'll see you back at 4:10.
If anybody had a question directly for Sam, because we didn't have quite enough time, but feel free to approach her. She's going to stick around for a few minutes. Thanks. Okay, so I'll kindly ask everybody to come back to your seats, please, and I'll just give you a minute before I introduce our next speaker. Okay, thank you so much. So I would like to welcome another one of our colleagues, Dr. Abdel-Razek. He is here to speak to us about tricuspid valve disease. He's an interventional cardiologist with expertise in structural heart procedures and recently joined the Heart Institute team. And thank you so much for coming to speak with us today.
Thanks, Liz, and thanks everyone for coming. So yeah, my name is Omar, Dr. Abdel-Razek. I'm one of the cardiologists here at the Heart Institute. And yeah, it's so nice to see so many people interested in valve disease. I feel like I'm the only person who's interested in valve disease, so I'm glad to see this many other people interested in valve disease. So I'm going to talk to you guys just a little bit about tricuspid regurgitation, which doesn't get as much press and as much play as the other valvular disease. It's sometimes called the forgotten valve, but I want to make it the no longer forgotten valve. So hopefully after this, you guys will feel as passionate about the tricuspid valve as I do. So what is the tricuspid valve and what is tricuspid regurgitation? So the tricuspid valve is a valve that sits between the right ventricle, which pumps blood into your lungs and gets it oxygenated, and the right atrium, which is a chamber that sits just above it. And the tricuspid valve, it withstands 60, up to 30 to 60 millimeters of mercury, so lots of pressure. And it prevents blood from going back onto your neck and onto your abdomen and onto your legs, and makes sure all the blood goes to your lungs. But when the tricuspid valve becomes defective or leaks, blood leaks back into the chamber just above it. So less blood goes to your lungs, more blood goes back onto your neck, and then your abdomen and your legs, and can cause significant symptoms related to that. So once this process starts happening, people will often complain about shortness of breath, fatigue, because not as much blood is going forward to get oxygenated, and then their legs and their abdomen will swell. And then with time, that can cause sort of irreversible damage to the liver and the kidneys, so cirrhosis and end-stage kidney disease. So it is a problem, short and long term. And in terms of how people do when they have tricuspid regurgitation or this leaking tricuspid valve, we know that people who have tricuspid regurgitation die sooner. So if you have a severely leaking valve, you're almost twice as likely to have an event within, this is kind of out to 4 years here, than if you have no or mild tricuspid regurgitation. So it is associated with worse outcomes. So who gets tricuspid regurgitation? So it's the most common valvular heart disease. Up to 6% of the population has this trouble. It affects women more commonly than it affects women. And it's more common in people over the age of 70. So elderly women are more likely to have this trouble. And we don't know, because not everybody gets tested for this. We don't know how many people have this problem, but the idea that we think that there's about 1.6 million people in the United States with this problem. So if you correlate that to the Canadian population, there's 160,000 people in Canada with moderate or severe tricuspid regurgitation. And I already told you that that's bad because they're these people here, and not these people here. So that's all worrisome, but is there anything we can do? So how does tricuspid regurgitation get treated? So even in my short-ish career, there was not a lot to treat tricuspid regurgitation when I was in my training. It was mainly treated with medications and surgery in people who are candidates. But as I've shown you, a lot of the people that get this are elderly, and the risk of surgery may be high with them. And medication alone sometimes is not effective. So then in the last 5 years, there's sort of been this explosion in the way we treat tricuspid regurgitation without doing surgery and above and in addition to medications. So this will be a little bit technical. Hopefully it's not too boring, but if I see people fall asleep, I'll move quicker. But there is transcatheter procedures, so tubes through the veins and the legs that we can use to treat tricuspid regurgitation. And kind of the best studied technique is something called tricuspid tear, or tricuspid clip. And it's exactly what it sounds like. It's this thing that looks like a clip. There's one over here that you can look at later. And basically what it does is it cinches the tricuspid valve together to make it leak a little bit less. And I have a video of how that works. I think this is supposed to work. I'm going to move it forward because it's a bit too... How do I turn the music off? I don't think we need... there we go. So basically we take a tube and we come up through the leg to the tricuspid valve. And the tube has knobs on the outside that allow us to turn it towards the tricuspid valve. I can move it along a little bit. And you'll see that it'll come down to the valve and sort of cinch it together like this. And the idea is, or what we know from research studies, is this causes the valve to leak quite a bit less. So not to bore you with bar graphs, but 90% of patients or 88% of patients have moderate or less tricuspid regurgitation when we treat them with this in a selected population, but it does work well for patients. The most important thing is that it's a safe procedure. So when they study this in hundreds of patients, the risk of something bad happening, something really bad happening, so a major adverse event, was 1.1%. So in terms of the types of procedures we do here at the Heart Institute, a very safe procedure. And there are things we're doing at the Heart Institute to make these types of procedures more successful. So we have cameras, an intracardiac echocardiogram, which is a ultrasound camera that goes up through your leg and takes pictures of the tricuspid valve while we're working to make it a little easier to see what we're doing and make the procedure a little bit more successful. And that's something that's gotten Health Canada approval in 2024, and we've done some procedures already with some more planned at the Heart Institute this year. There are other things we can do through catheters to treat tricuspid valve disease. Another new option is transcatheter valve replacement. That's where we take a valve from the leg again and we replace the valve that way. So I think this is another video. So big tubes through the legs. Oh, is the video going to play? Here we go. I hope it doesn't give us an ad. If it does, I'll move along. it's not working. But essentially what happens is this valve comes up through the leg and it sits where the old leaking valve was, and it closes properly to stop that leaking onto the neck and legs. And that, gets rid of tricuspid regurgitation altogether. So if you look here, 99% of patients that they studied this in had not very much tricuspid regurgitation or tricuspid leaking. It has slightly higher risk, so it's a more risky procedure, but a more effective procedure and one that will continue to improve. And we have access to this at the Heart Institute, just using a different system called the cardiovalve system. And then finally, we have sort of other novel procedures that we can do where we protect the liver and kidney as well as the neck using these two valves that sit in the veins that are behind that valve that's leaking to prevent the end organ damage or sort of irreversible damage to the organs. And that's pretty novel. That only started being done a year or two ago, and we have access to that at the Heart Institute as well for patients who aren't candidates for the other procedures that we talked about. And this is just another system that also blocks the valve to prevent it from leaking that we have access to at the Heart Institute. So all that to say, it's an under-recognized problem, affects a lot of people over the age of 70, affects women more than men. And there's been this explosion in innovation in this world in terms of how we treat this. And there are many treatments out there for patients that can help improve symptoms beyond medications alone in patients who aren't candidate for open heart surgery. And that's sort of all I have to say.
Does anyone have, we might have time for one question before our next speaker. Does anyone have a question right away for Dr. Abdel-Razek?
What is it about the tricuspid valve that makes a surgical repair or replacement risky?
So as with anything in medicine, there's risk and benefit. So fixing the tricuspid valve, though it is associated with increased risk, doesn't necessarily make you live longer. I didn't show all the literature, but it doesn't necessarily make you live longer. But the surgery is associated with risk of, being in the intensive care unit. There's risks of infection. There's risk of needing blood transfusion. There's a risk of kidney injury. So the risk-benefit ratio for the tricuspid valve alone is much higher than is much different than the risk-benefit ratio for, say, if you had, a number of blockages in your heart arteries with a bypass surgery or an aortic valve replacement, because the benefit can be higher in those patients.
If I may make a comment as well, one of the main risks of the surgery in patients with tricuspid regurgitation is that they are seen too late. Like in every disease, every valve disease, patients are referred too late, and it's impacting a lot the outcome. So early intervention.
All right, thank you.
Thanks, Dr. Abdel-Razek. I think he'll be back if there's more questions for the panel discussion later on. I will not forget about the tricuspid valve, for sure. Our next speaker is Dr. Labinaz. He is here to talk about mitral valve disease and the mitral clip procedure. Dr. Labinaz has worked at the Heart Institute for quite some time. He has a wealth of knowledge and experience in interventional cardiology and valve procedures, and he has been a very integral part of establishing these minimally invasive valve programs here at the Heart Institute. Thank you so much for being here with us today, Dr. Labinaz.
Thank you very much. Well, thank all of you for coming today. I really appreciate you taking time out of your day and weathering the cold and digging out of your driveways to come for this valve today. I want to thank Dr. Messika for organizing it. He's really helped us develop the program, and Liz for the introduction. Liz runs our TAVI program. I'm not sure if you've had the TAVI talk before, but she's the glue that keeps that very busy program all together. So Dr. Messika has asked me to speak about transcatheter interventions on the mitral valve. So what I'm going to do today first is just describe the anatomy of the mitral valve, some basic ways that the heart works, then some symptoms, and then some of the interventions. I have some videos, actually live videos of a patient I just recently treated. And then again, we'll have questions at the end, hopefully. So so going back to our high school anatomy, this is the heart. I'm not sure if you've gotten any talks on this today, but just very quickly, blood with low oxygen comes from this large vein up here, this large vein down here, and pools in the top right chamber called the right atrium. When this is full, this tricuspid valve opens, allowing blood to go down to the right ventricle. It then pumps blood up through this artery that brings it to the lungs, which are out here. The lungs oxygenate the blood, and then there are typically 4 veins that brings this oxygenated blood to the left upper chamber called the atrium. There's a valve here called the mitral valve. When this is full, this valve opens, allowing the blood to drop into the left ventricle, which then squeezes blood through the aorta to the whole body. Now this is going on simultaneously. So these 2 top chambers are squeezing at the same time, and these 2 bottom chambers are squeezing at the same time. And they're delayed because there's an electrical activity in the heart that sends a signal to make these contract. Then there's like a relay station, waits a few milliseconds, allows it to relax, and then it goes down. So that it's kind of a sequential pumping action, all right? And so the purpose of the valves in the heart is to ensure that the blood goes in one direction, right? So you want the blood always going forward. So when this part, the left ventricle, starts to contract, you want the aortic valve to open, but you want the mitral valve to close, because you want the blood going this way, not that way. All right, does that make sense to everybody? So in cardiology, when your doctor listens to your heart, we listen to different sounds. So the first heart sound that we listen for, you know, the lub-dub, you've heard of that lub-dub? So lub is this valve closing. So when the heart contracts, the mitral and tricuspid valves close, and that snapping action creates a lub sound. And then these chambers contract, the ventricles, and they push blood through the aorta and the pulmonary artery. And when that relaxes, that causes the dub sound. And so we can tell when a valve isn't working properly because these valves are either narrowed, so the blood is turbulent going through in the forward direction, so we hear a sound, a murmur is what we call it, or it happens at a different stage when the valve is supposed to be closed and we hear regurgitation, okay? Or leakage. It's not really leaking. When we use the term leakage, it never leaves the heart. It's just regurgitating or going the wrong way. And depending on if it happens before or after the first heart or second heart sound, we can tell if it's mitral or tricuspid regurgitation, mitral and tricuspid versus aortic or pulmonic regurgitation. Now the tricuspid and mitral valves, the tricuspid and pulmonic valves are harder to hear because they operate at a much lower pressure. So a lot of these sounds that we're hearing are on the left side, the aortic valve and the mitral valve. All right. So my talk is about the mitral valve. So I'm going to focus in on this guy right here. So remember, its job in life is to open, to allow blood to go to the left ventricle, so it gets pumped to the body, and to close when the left ventricle contracts, so the blood doesn't go backwards, gets into this left atrial chamber, into the veins, that goes back to the lungs, which raises the pressure, okay? Unfortunately, the mitral valve is an extremely complex structure. You know, there's the valve structure, which is this here, and we label it so we can talk about it. So there's 2 leaflets or 2 doorways, the anterior leaflet and the posterior leaflet. And there's typically 3 scallops to each leaflet. So we call it A1, A2, A3, and P1, P2, P3. That's so that when we're talking to each other, oh, this is a P2 prolapse. So we know that this part of the valve is not working properly. Now, in addition to the valve, you can see how the valve is structured inside the heart. It's it's attached to the heart, with most of it being surrounded by muscle. And this becomes important because this is one of the mechanisms by which this valve can fail. It's also tethered to the heart through little cords. We call them cordae tendineae. So they're like the parachute things, okay? And they're attached to these muscles in the heart called the papillary muscles, which are then attached to the heart. Now, the fascinating thing is that any defect along this chain, going from the valve to the heart that supports the valve, to the chordae, to the papillary muscle, or to the heart, can cause the mitral valve to malfunction. Okay? And so Dr. Carpentier is a cardiac surgeon who came up with this classification many years ago, and he's got 3 types of regurgitation. We've simplified it now. We call it primary or secondary or functional and degenerative. We usually use the words functional and degenerative now. And what we mean by that is that if it's degenerative, that means that the valve itself is broken. All right? So either you had rheumatic fever, for example. That would be, that's this guy here. The valve becomes thickened and doesn't open and close properly. You could have an infection of the mitral valve so that the bacteria breaks it. You can develop a hole in the mitral valve. Those are all degenerative problems of mitral valve regurgitation. Now, you can have functional mitral regurgitation where the valve itself, like if you took the valve out of the heart and looked at it, it would look perfectly fine. The problem with functional mitral regurgitation is that the structure around the mitral valve is abnormal. So what can happen there? So one thing here is that the heart can dilate. So think of it this way. The heart was made to keep the 2 leaflets like this. But if the heart dilates, for example, if you have atrial fibrillation for a long time, or you've had a heart attack and your heart dilates, or you have a cardiomyopathy, the leaflets will be pulled apart. There's nothing wrong with the leaflets. They're functioning just fine. It says they're just, and so now they can't meet in the middle anymore. So there's nothing wrong with the valve. The problem is functional. It's around the heart. The other thing that can happen after a heart attack, for example, is that here's an example of a heart attack. So scar tissue forms in the heart. And you can see how this muscle, which has got these cords attached to it, so the heart attack causes scar tissue, and that causes the cords to be tugged down. So rather than the leaflets meeting like this in the middle, one leaflet is pulled down like that. So they're not meeting in the middle anymore. Okay? Or the heart can dilate or stretch right out. So the leaflets then get pulled out to the side, and so both leaflets can't come up anymore. So those are functional examples. A common degenerative example is something that we see with mitral valve prolapse. So that's a degenerative tissue problem of the heart valve where the leaflets become thick. They almost look like sails in the wind. And the chordae, these little cords, aren't as strong. So these cords can rupture or break. And you can see that this leaflet, which should be pointing down like this guy, is flopping up in the air. So it can't close. So that's a degenerative problem. We call that a flail leaflet, okay? So those are the common causes of mitral regurgitation. And so here is a video. So focus on here. This is a left ventricle. This is a mitral valve. Oops. I got this from YouTube.
The mitral valve is located between the upper left heart chamber, left atrium, and the lower left heart chamber, left ventricle. A healthy mitral valve keeps your blood moving in the right direction. A leaky valve doesn't close the way it should, allowing some blood to flow backward into the left atrium. If left untreated, a leaky valve could lead to
All right. Why do we care? So you have mitral regurgitation. What's the big deal? We care a lot because mitral regurgitation has this vicious circle where what it does is it increases pressure in the top chamber, which then causes muscle loss, which then causes the pumping chamber to work harder. It becomes weaker. It then begins to dilate. When it dilates, remember I said that it can stretch the valve out. So it stretches the valve out, makes the regurgitation worse, and it goes around and around in the circle until it gets really bad. And why does that matter? Well, it can lead to many problems. It can cause atrial fibrillation, which is a fast, irregular heartbeat. It can cause pressures to elevate in your lung arteries. That's called pulmonary hypertension, congestive heart failure, and unfortunately death. So what are some of the symptoms of severe mitral regurgitation? These are not sort of specific for mitral regurgitation, but they are associated. So these are some of the things that you would see if you have mitral regurgitation. You develop a shortness of breath, usually beginning with activity. Then you'll have shortness of breath or coughing, particularly when you lay down because you're redistributing blood into your lung tissue. Waking up in the middle of the night, coughing or being short of breath from a deep sleep is also a sign of heart failure. Sometimes you'll get chest pressure because of the increased pressure on your lung arteries, swelling in the legs, and fatigue. You can also have palpitations because your heart goes into an irregular beat called atrial fibrillation. So those are the symptoms. So the quality of life goes down, but now the quantity of life goes down. So this is an old slide from 2014. Things have gotten a little bit better, but not great. So these are patients that were followed with severe mitral regurgitation and were untreated, except for medicines. Okay, we have better medicines now, so the numbers aren't quite as dire, but they're not much better. So if you have severe mitral regurgitation and you're treated with medicines, your chance of dying in 1 year is 20%. Your chance of being dead in 5 years is about 50%, like many aggressive cancers. Your chance of landing in a hospital in 5 years is 90%. The chance of being in a hospital in the first 2 years is around 50%. So both the quality and quantity of life is poor in untreated severe mitral regurgitation. So clearly we have a big kind of oomph to treat this condition. And here comes the mitral clip. Dr. Abdel-Razek showed this. In fact, the tri-clip came from the mitral clip. Back in the day when we started this, we would do drive-by tricuspid clipping. So I'd go in there, we do the mitral valve, and sometimes the tricuspid valve also gets degenerated. We'd put 2 clips on the mitral valve, and on the way out, because it's on the right side, we put 1 or 2 clips on the tricuspid valve. We had good success with that, so the companies were able to redesign the system to make it more specific for the tricuspid valve. So the tri-clip system has got the same principle, but the device is slightly more adapted for the tricuspid side. So this is a system that he was showing. It's very similar. So this tube from here all the way up to goes into the heart. So this part here is outside the body. And here are knobs that allow us to move in 3 dimension. Okay, so we can put the clip in, rotate it, and do all the things that we want to. And this is the purpose of all this, is to put this little guy in to bring the 2 leaflets together where we find the defect and clip them together. So what is a mitral clip procedure? It requires general anesthesia because we have to leave a transesophageal echo probe down to guide our work. So people are put to sleep. The TE probe goes down. We go up through the vein of the leg. Now this is an 8 millimeter diameter device, so we make about a centimeter diameter incision in the right groin. And then we work to deploy 1 to 4 clips. And people ask me, well, how do you decide? Well, simply, we keep putting in clips to get rid of the regurgitation without over-narrowing the valve. So if we put 1 clip in, it looks great, and the valve isn't narrowed, we're done, short day. If there's still regurgitation, and there's no narrowing, we measure the degree of narrowing, we put the 2nd clip in. And we keep working to try to get rid of as much regurgitation without over-narrowing the valve. And so we keep doing that on a continuous basis, and we assess that. On average, it takes us 2 hours to do the procedure from start to finish. And we're successful in 95% of people now in reducing severe regurgitation to a mild or 2+ degree. As Dr. Abdel-Razek pointed out, the risk of adverse events, even with this procedure, is low. And the majority of patients, I think it's 80% now, go home the next day. So this is an actual procedure done. So I'm going to try to orientate you. This is a transesophageal echo. So this is a probe in the heart. This is the mitral valve here. And this is a leaflet here. This is the left ventricle down here. And this is the left atrium here. Okay? So if you look here, you see that thing flopping in the breeze like a sail? That's the broken mitral valve. So this was mitral valve prolapse, the cord's broken, it's flying out. So now we put color on it. Color really makes it really stand out, and I have a before and after, which is kind of cool. You see all of this abnormal color? You shouldn't be seeing that turbulent yellow-red stuff. That's blood regurgitating through the mitral valve into the left atrium. So now this is us positioning the clip. So now we are working in 2 planes. So our expert echocardiographers puts the probe down, and we do, these are perpendicular pictures to each other. So here's the broken leaflet. We're looking at it from side to side and front to back. And here we're positioning the clip right over the defect. So here is the floppy portion of the valve. Here's the front leaflet. This is the back leaflet. And we position it to be right on the spot. So here's the heart beating. You can see the clips open. And now once we position it to where we want it, we grab the leaflets. So the two arms are underneath, we come up to the valve, and there's these little pinchers that come down that grab the leaflets between the arms and the pinchers. And you can see that here. You see how now we've grabbed the leaflets, they're no longer flopping in the breeze? Once we're convinced we've grabbed them well, we then turn a knob and we close the clip. So we grab the leaflets with our arms out like this. Then there's an arm that brings the two arms together like this, pinching the two leaflets inside the clip. And you remember all that spray that we saw before, that yellow-red stuff? We put 2 clips in this patient. Look what there is now. Just that little whiff of regurgitation. You see that little jet that's there? I can show that to you again. See that little flame right there? Not the red one, that yellow one. That's all that's left. You remember the big wide one that we had? So this person is doing fantastic. I just saw them in clinic. This was done 2 weeks ago. They had terrible shortness of breath. They're now walking 40 minutes a day across one of the bridges to go visit their son in Quebec. And this is a 3-dimensional picture of the valve that's created. So you can see the 2 clips inside the valve here. And you see there's one opening on this side and one opening on this side. So you can see now that we keep working, but if I add more clips in, I just shut the valve off. So we have to use our judgment to get it down to that small degree. We rarely get rid of it completely, sometimes we do, but to get it down to that small degree, our body can tolerate 2 degrees of mitral regurgitation without any consequence. So take it from 4 down to 1 or 2 is our goal all the time. So I'm going to show a couple of studies just very quickly. In medicine and cardiology, we like to study our treatments. When do I finish? Okay. So I'll go through this a bit more quickly. So we always try to see if what we're doing is right. So we do what's called randomized trials. And what that means is that by computer allocation, we take patients who are eligible for a treatment, half get randomly allocated to the standard treatment and half to an experimental treatment, whether it be a pill, in that case we use placebo, and this trial was done almost 20 years ago. It was against cardiac surgery. So half the patients got cardiac surgery and the other half got a clip procedure. And again, I was just after this, so we've been doing these about 15 years. I can tell you the way we do clips now is completely different than we did clips 15 years ago. We've learned so much, and it's actually shocking to me that the results of this research trial was as good as it was. I think if it was repeated, it would be amazing. So what we found in this, we found that in patients who got the clip, it was much safer than surgery. The clip patients only had a 10% adverse event or complication rate, as opposed to cardiac surgery had close to 60%. That includes blood transfusions, and people have argued, is that really an adverse event? But surgery did give you a better result. So 72% of the clip patients had reduction of their regurgitation, while 88% of surgical patients had a reduction. And the major benefit, so the mortality was really the same between surgery and mitral clip, but the major benefit really came in people, because one of the endpoints was redo surgery. So this is where it was kind of stacked against the clip, because all the surgery patients had surgery. And so 20% of the mitral clip patients had surgery. So there was a 20% failure rate. But I can tell you now, our failure rate is less than 3%. So that's why I'm saying that things have changed so much in 15 years. One thing that we noticed is that there was a dramatic reduction in hospitalization for heart failure, almost a 60% reduction with the clips. So some smart people got a good idea. We were part of the trial where we could use mitral clips to try to reduce symptoms of heart failure in people who have not problems with their valve, but simply functional MR. So their heart was either dilated or the leaflets were pulled down. And can we add this to the regular heart failure therapy, which is medications plus a specialized pacemaker? So standard therapy plus standard therapy. So we're not eliminating anything, but we're adding standard therapy plus a clip. And this trial was actually surprised the world. because it was so, this is all the introduction stuff. So they basically took 305 patients, they got medical therapy plus a clip, and this group got medical therapy only. And this was considered the experimental arm because we didn't know that the clip would help patients with heart failure. And this was how we normally treated patients. I'll zip through this. And you can see here again, just to point out how much better we are. So if you add these two numbers together, we're at 95% now at reducing the regurgitation to 1 or 2 plus. Okay, 95% ability to reduce it down to 1 or 2 plus, which is quite dramatic. And this is where the punchline comes in. So when they look at 2 years, in the patients that did not get the clip, 151 patients of the 300 landed in hospital 283 times. Compared to patients who got the clip, 92 patients out of the 300 some patients landed in hospital for 160 total admissions. This was equally surprising. At 2 years, there was an absolute 15% reduction in death. That's only at 2 years, and the lines are continuing to diverge. So if you got a clip, you had a 40% reduction, almost a 50% reduction in the chance of dying compared to the best medical therapy that we had. So this is not like compared to nothing. This is compared to the best medical therapy we had. So a really dramatic improvement. And if you look at the combined incidence of dying or landing in hospital, again here you have a 50, so you have a 50% reduction of landing in hospital. So very dramatic, very important results with the mitral clip. So that's become a standard treatment for people with heart failure symptoms and severe mitral regurgitation. This is a very complicated slide, but I'm basically showing it that we looked at all different types of people, whether you're young or old, so over 75, under 75, if you're a man or a woman, if you had, you know, how bad it was, if you had high risk or low risk surgery. In every subgroup that we looked at, people that got the clip plus the medications did better than people who just got medications. Okay, there wasn't a group that seemed to do better versus the other. So it looks pretty standard, ubiquitous to be applied to all patients. So what's our heart team look like? So this is not a one-person show by any means. It's a huge team of people. So we have a multidisciplinary approach here. We work closely with the heart failure doctors and other cardiologists. We have specialized echocardiographers that assess the mitral valve for us before and after. We have specialized echocardiographers during the procedure that can guide our work while we're doing it. We have interventional cardiologists like myself and Dr. Abdel-Razek, and cardiac surgeons like Dr. Vince Chen and Dr. Al-Atassi, who work together during the procedures with the echocardiographers like Dr. Nicholson, Dryden, Hines, and Brad. And we have great institutional support. I'm going to tell you this. The company won't want me to tell you this. Each clip procedure is $32,000 Canadian. So what are the type of patients that we treat? So if you have symptoms of New York Heart, 3 or 4 symptoms, there's a class that we have. If you have functional MR, like if it's due to a distorted valve, all comers. Now, if you have degenerative MR, surgery still remains the gold standard. So if you are a young, healthy person, if you have a flail leaflet, then surgery still remains the gold standard, although we are doing a research study now seeing if clip, because we've advanced so much, is as good as surgery. And we do not do mitral clip for patients who have artificial valves, who have rheumatic fever, who have an infection on their valves, or that they've had prior surgical repair of the valve. And we have to be approved by the heart team. So every Wednesday morning at 6:45, we get together with about a dozen of us to look at all the referrals of the week and their TEEs to decide if this is the best treatment for the patient. So in summary, severe mitral regurgitation is bad. It leads to symptoms and death. Mitral clipping is safe, improves both quality and quantity of life. We're now doing a study of looking at mitral clipping in people in shock when they're in the intensive care unit, whether that helps them. And I already mentioned that we're comparing mitral clip to surgery in patients who can have cardiac surgery. Now, unfortunately, not all patients can have mitral clipping or cardiac surgery. So as Dr. Abdel-Razek pointed out, there are novel therapies that are coming out, and there's One called the cardiovalve, and this is the example. So again, this is all used to maneuver the valve in three-dimensional space. And this is the valve that we put in the mitral valve. So we're going to do the first North American implant in 3 weeks' time. So that cardiovalve patient, we've gone through all the regular channels, and so we're now at this point in time. So we're going to do, we've done 2 tricuspid valves, and we're doing a few more coming up. So this is really fairly cutting edge technology. And that's what I have to say. Any questions?
Excellent presentation. Thank you, Dr. Labinaz. Are there any questions?
Just wondering, your earlier experiment comparing cardiac surgery versus the clips. And if I remember correctly, they are similar in the earlier study, isn't it?
No. So in the first study that I pointed out, the results of that study showed that clip was safer, less complication rates, but surgery was more effective in reducing the regurgitation.
Now here, that's what I was wondering. The clip is actually less invasive than the surgery.
Much less invasive.
So now, did they take into account the consequence of surgery where you're actually introducing trauma to the myocardium, and that later on can develop electrical conduction problems?
We didn't see a signal of that in the trial at all. There were, like I said, there was more complication rates with surgery, which, as you pointed out, is intuitive, right? It's a more traumatic, more invasive procedure, but more effective. The clip, much less invasive. Like I said, the incision is a centimeter, not 12. But back then, it wasn't as effective. As I mentioned, we've learned so much about clipping now. I would propose if we do, and this is my hypothesis, that if we repeated the trial, I think clip would be safer and equally effective. That's my prediction.
I think we have time for one more question.
Pardon me? Oh, that the clip? No, it's stainless steel and Dacron is the material. Yeah. Yeah.
Excellent. Thank you so much again.
Thanks.
So our next speaker is Sandra Wong, who will be discussing the mobile screening program and the patient journey. Sandra is a registered nurse who works in the Center for Valvular Heart Disease as the project lead for the mobile screening program. She organizes the program, networks with community partners, and runs the clinics in the community. Welcome, Sandra.
You so much, Haley, for that introduction. And hi, everyone. I'm so pleased to be able to talk a little bit about our mobile screening program. A little bit kind of in addition to kind of what we've learned already about valve diseases is more about the screening part of it and prevention. So yeah, so I'm happy to share about that. I'll also introduce our patient partner, Hannah, who also participated in our program and will be part of our panel discussion today. So I don't need to go over the details again. I think we've heard it from many of our speakers today. Valvular heart disease, as we all know, is more prevalent as we have a aging population, and its incidences are, of course, increasing in Canada. It's often underdiagnosed, undertreated, and referred late in the course of disease. So kind of bearing in mind that reality and the evidence that we see in research about valve disease, we've kind of decided as a Center for Valvular Heart Disease that it's really important to diagnose early and to expedite referral and treat valvular heart disease in a timely manner. So that's really what our mobile screening program exists for. And how does it work? What is it like? Well, anyone who's 65 and above with no cardiac history or stroke can participate. And essentially, participants get a review of cardiac risk factors. So that involves doing some blood pressure with the nurse, height and weight. We also do a little poke in the finger where we're checking for cholesterol as well as HbA1c, which is the average blood sugar in the last 3 months. And then in addition to that, we also do a mini heart ultrasound done by the registered sonographer. So you heard from Sam earlier. So she and along with other sonographers help perform some of these mini ultrasounds during our mobile screening program. And then once the participants have done all this testing, they actually get the results of the testing after the visit. But just kind of going in more depth of what we actually look for in that mini heart ultrasound, it's very much of what we had actually all talked about. So we look for any significant aortic valve stenosis, regurgitation, as well as any mitral valve stenosis or regurgitation and tricuspid regurgitation. We can also see, because it is an ultrasound, we can also see non-valvular abnormalities. So sometimes we can see if there's any poor functioning poor heart pumping function. And we can also see if there's any enlargement of the aorta, which is that big vessel off the heart. And with those results of the testing, we actually have some next steps. So if we do find things, there are things that we would recommend to the participants. If there's any valvular heart disease that we do find that are moderate to severe, as I just mentioned, they actually get an automatic referral at the end of their visit, and they get seen here at the Heart Institute by one of our cardiologists. They also get a formal heart ultrasound. So instead of the mini one, they get another larger one, and it's about 45 minutes and more pictures to confirm the findings. And so that is all streamlined if we find something valvular in their tests. If we find something non-valvular, like I just mentioned, of poor heart pumping function or an enlarged aorta, if it's urgent, then we will send them either to the emergency department or to one of our rapid access clinic here at the Heart Institute to be assessed. If it's non-urgent, we will then refer them back to their family doctor for follow-up after that. As I mentioned, participants also get an assessment of their cardiac risk factors. So we are checking for blood pressure, we're checking for cholesterol, diabetes. If it's not been treated before and it is new and uncontrolled, so sometimes we do find, for example, high HbA1c, which is screening for diabetes, and people don't know about it, then we will actually refer them back to their family doctor or to a walk-in clinic to have that managed for the long term. Along with giving those recommendations, the nurses also give lots of education. So these are only some of the examples of some of the educations we give. So for example, we provide information about how to measure your blood pressure at home, how to quit smoking, how to manage pre-diabetes. So lots of different information that we also provide in terms of the visit. So at the end of the visit, participants will be given the opportunity to do our survey, and the survey is voluntary, but it provides us feedback that helps our programming of the mobile screening. And in addition to that, if a participant did get recommendation, let's say to follow up with their family doctor for high blood pressure, then at the 6-month and 1 year's time after the visit, they get a call from the nurse and gets follow-up about how the recommendation was taken and whether there's other steps that need to be done. So who's involved? Like all programs, it's really a really big team effort. We are spearheaded by our director, Dr. Messika-Zeitoun, as well as our manager, Cindy Cross. But of course, there are many nurses that are involved, registered sonographer, administrative support, as well as research support. And actually, we also got some research funding at the beginning to get our program going for the last year and a half. So how do we recruit participants? We recruit in a number of different ways. We liaise with key community leaders. We do advertisements on radio, Facebook posts. We target certain population groups where valvular heart disease or cardiovascular disease may be more prevalent. And so we kind of look at doing the screening at public spots. We do ethnic community groups, rural places, apartment buildings where there's a high concentration of seniors. So a number of different places. These are some of the partnerships that we've built over the last since we started the program. So we have a number of partnerships within the city of Ottawa, but actually also outside, like Arnprior. And we've also got a few ethnic groups that we've also worked with a number of times. So how does registration happen? If you're interested or you're wanting to know how we get our participants, we actually have on our website information about registration. So here on the left, you can sort of see our web page, and that red button actually allows you to fill out a secure form with information about your contact, as well as some information where you can answer some questions about your heart history. And for those who can't complete the online form, they're welcome to call our Center for Valvular Heart Disease office to register as well. So this is just a little bit of the background, just for you to get a sense. So how do we get around? How are we truly mobile? Well, as you can see on the picture on the right, we put a lot of things in bins and cars, and we just drive to places. We have a lot of machines that we bring with us. We bring a massage table as well for the ultrasound. We bring all sorts of equipments like gloves, etc. So we are really equipped to be mobile and going everywhere in the city and outside. And how does a day look like in our mobile program? So really, you can see here on the right, these are some actual real life examples of how we set up. So sometimes we're in little libraries, living rooms of apartment buildings. Other times we're in mall storefronts. So whichever way wherever we are, we try to maintain the best privacy and confidentiality for our participants. And we also try to be as accessible as we can wherever we go. So just to provide a little bit of an overview of our initial outcomes with the program, this is a map of all the different areas that we've been to so far. And the program started in May of 2023. Initially, it was one mobile screening program clinic per week. And since September 2024, we've increased to 3 clinics a week. So we've done a number of different locations, as I mentioned, primarily in the city of Ottawa, as you can see, sort of all over the city, but also rural sites within the Champlain region. And also, we've also done 3 Indigenous reserves as well. So how many people have participated? We've had 2,330 participants that have joined our clinics from the end of January since the start, and that's 135 clinic days. And the demographics of our participants, they're primarily female. Average age is sort of 74 years, and most of them do have primary care provider, at least to be named. And then in terms of other kind of demographics, there's about 4% that are current smokers. And as you can see here on the slide, many of them, about 40% are treated with high blood pressure. About 40% are treated with high cholesterol medications. About 13% are on some diabetes medication, and about 1.2% are treated with obesity medications. So what have we found since May 2023 to now January 2025? We have found about 6.43% of valvular abnormalities. So that's about 143 people that we've either found, yes, that they have aortic stenosis, regurgitation, mitral regurgitation, tricuspid regurgitation, or mitral stenosis. And then 60 that are uncertain of those. And the uncertain kind of comes into those numbers because they get confirmed again with a formal heart ultrasound to see what it's like. The other thing we also, as I mentioned, look at is the non-valvular abnormalities. And most commonly, the ones that we do find are enlarged aorta, as well as the left ventricular dysfunction or poor heart pumping function. So in terms of what we've recommended for these people with these findings, first recommendation, so the ones that we did find valvular heart abnormalities for, 5.6% were sent to our Center for Valvular Heart Disease, so seen by a cardiologist, done another heart ultrasound. 5.4% were sent back to their family doctor to do a formal heart ultrasound, and for the family doctor to follow up after that. And as you can see, a few were sent to the Rapid Access Clinic and a few were sent to the emergency department. Surprisingly, we've actually found a lot of people with new and uncontrolled cardiovascular risk factors. So almost, if you can see between the first and second recommendation, almost a third of the people that we do see actually have new and uncontrolled either blood pressure, diabetes, or high cholesterol. So quite significant that way. In terms of feedback surveys, this is a busy slide, but all this to say, as participants finish up their visit, they can give us feedback. And we did do sort of Likert scale of what their thoughts are about our program. And as you can see here in this graph, the dark blue is most of them answering strongly agree, and the orange is also agree for things like that this program benefits their quality of life, benefits their access to health care, that they would recommend this program to other family and friends. We've also gotten lots of qualitative feedback as well, some good and also some very constructive feedback. So some of the quotes here, for example, got great information. One suggestion is to do some more with layman terms. So that's a good feedback for us as staff to make sure that we're speaking in a way that allows everybody to understand what we're talking about in terms of valvular heart disease. Other kinds of constructive comments, like, for example, better signage. Sometimes we're in malls and it's really hard to find us. So it's quite simple, but these are super helpful feedback survey kind of comments. So I know it's still winter, but I thought I'd use the kind of image of butterflies because, there's always something to look forward to in the spring. And sort of like butterflies kind of changing, our program is also growing and it's also changing and it's also evolving, if you will. So with some of the feedback that we've gotten from the clinics, as well as just kind of trial and error, we've done a couple of things. So first, we've extended our screening at certain places where we're screening actually not just 65 plus and above, where we're screening for those also 18 and above, all the way to whatever age. We are also exploring new partnerships, and we're also trying to increase team capacity and also increasing clinic days per week. The other thing that we're trying to do is we're trying to grow into a mobile bus model. So that's our kind of ultimate goal, where we're really truly mobile and we can go anywhere but have all our equipment in one place. So just to kind of end our presentation here, I just want to introduce Hannah, who's going to be part of the panel discussion. She participated in our MSP clinic in August last year, and we ran a clinic, and actually during that mini heart ultrasound, we found that she had moderate to severe aortic stenosis. And she came back in the fall to see us in November. She had another formal heart ultrasound. She saw the cardiologist, and it was confirmed she did have severe aortic stenosis. And at the time, she felt a little short of breath and fatigued, and she also had some episodes of chest pressure. So after some discussion with the cardiologist, they talked about doing that TAVI procedure, as we've heard much about. So she was referred to the TAVI team. And in December, she saw the TAVI team, had the discussion about what that looks like in terms of a procedure. And actually mid-December, she had the TAVI procedure. And a prosthetic valve was put in, as we heard of what that is like. And it's doing its job really well. So we'll actually be able to hear more from Hannah in the panel discussion shortly. So just a little advertisement, I guess. So if you're interested, I do have a table and booth over there. Happy to chat with anybody who might be interested in participating. For those virtually, you can see the information about our program on our slide here. All right, thank you so much.
Thank you so much, Sandra. That was fantastic. And Sandra will be on the panel discussion later this afternoon if you have any questions for her. And next, our speaker is Dr. Vincent Chan, who will be discussing surgical options for valvular heart disease. Dr. Chan is a cardiac surgeon and assistant professor in the Department of Surgery at the University of Ottawa. He specializes in mitral valve disease and interventions, including both surgical, minimally invasive, and catheter-based options, and has been a staff physician at the Heart Institute since 2012. Welcome, Dr. Chan.
Great. Thanks for that introduction. Sorry for creeping beside you while you're doing the announcement. I was delinquent and I did not send the slides, so I apologize to Sandra and everyone at the back table for being so difficult to kind of manage. This is going to be a difficult talk because I understand on the agenda that I am stopping you from having dinner, but this will be a surgeon's talk, so there's going to be a lot of pictures, video, not a lot of data, and very privileged to present today. So one of the surgeons, a professor within the university, also privileged to be the vice chair of research for the Department of Surgery. So, when you look at the guidelines for surgery, this is kind of what we look at. So published in the journal Circulation, we have these guidelines from 2020, which are still applicable now. And where we usually get involved as surgeons is kind of stage C and D disease, kind of severe disease where you may or may not have symptoms. And in the context of mitral valve disease, where I spent a lot of time looking at this valve, we do see patients that may not have symptoms, but have severe valvular disease. But when you get a bunch of patients in a room and you ask them who wants to have surgery, I feel like this is what people feel, right? Like no one wants to get cut open. And then you're that fella that comes in and says, well, maybe you need to get cut open. But as surgeons, we do a lot of different procedures. I find that we look after patients like this. Like there's really two ends of the pendulum that swung really hard, where you really have maybe very young patients or very healthy patients where you can do a very fancy minimally invasive surgery that's not catheter based. Or on the other end, you may be tasked with a very, very sick patient that actually was even too sick to have a catheter-based therapy. So I'm just going to highlight maybe two cases over the next several minutes to kind of describe this. So when we look at surgical approaches, I just want to make sure we talk about the whole thing, that we're on point, is that there's different ways that we can kind of get into a human being. So you can either do an incision on the left, and this is in the context of mitral valve reconstruction where you don't have to harvest conduits, but you can make a small midline incision on the left where you can make an incision about the length of a smartphone. You go as cranial as maybe the manubrium. And of course, we can do minimally invasive or thoracotomy type access for certain patients. So I'll present to you two cases. The first one is a nice lady. She's 84. This was a patient that I actually looked after last month. She has a few candles on the birthday cake. Still lives at home, usual cardiovascular risk factors, small individual. And where a small individual matters is because if you're a little bit smaller, you get you on the heart-lung machine, you're more likely to get transfused because what connects you to the heart-lung machine is tubing, and that tubing is all filled with crystalloid fluid. So it is a risk factor if you're a little bit smaller. So this was a bit of a consideration. She lived alone, super functional, but limited a bit in her mobility due to her arthritis. We have this thing called MAC, mitral annular calcification. It's basically the door frame of the door is just very calcified, which actually precluded her from having a catheter-based strategy. Her heart was in good shape. So on the panel on the right, we have what's the Society of Thoracic Surgeons risk score. So we have this risk score of 1,100 hospitals that basically contributed data in North America for the last 20 years. And based on statistics, they can estimate what a patient's mortality and morbidity would be. So if I just dial this into the online website, we get a predicted mortality, operative mortality, so death either at surgery or within the first 30 days of surgery of 5.6%, and then a morbidity or mortality of like 18%. So pretty serious odds, right? So if you're going to go for surgery for someone like this, you have to obviously have a really clear conversation about, what you're talking about. Now, this is data from 1,100 hospitals. So we have some data. I'm not going to show you all this stuff, but sometimes we can do a little bit better. This is the patient's CAT scan. And the reason why I want to show you this is because white is bone. Right. So if you look on this panel, you can see where the mitral annulus sits. You have a ton of calcium on this axial shot. This is worm's eye view. This is left side. This is right side. And you can see all of this calcium here. And this is a sagittal view where it basically cuts the patient in a different plane. And you can basically see all of this white that lights up. And if you look at the echo from this, which I can play, and I feel very humbled to look and echo with Dr. Messika in the back. But basically, you have the mitral valve here, you have the anterior leaflet, you have the posterior leaflet. This stuff here, this is just a big hunk of calcium. So you know that whatever you need to do to this valve, you need to actually handle a bit of this calcium. Now, one of the things that we always worry about when we talk about mitral annular calcification is that the electrical system of the heart is around there. So the conducting system is around the annulus. You have vital arteries. You have the circumflex coronary artery that lives in there. So there is a thing where if, depending on what you do in this area, if it starts to tear, you can actually have the top and bottoms of the heart separate. And if that happens, you can envision that it's not congruent with life. So this is another view here of, hang on a sec, of, yeah, so basically this kind of shows this jet of mitral valve regurgitation that goes into the left atrium. So we've studied MAC a little bit over the years. So the stuff on the left is stuff that we published almost over a decade ago, looking at MAC. And what do we find? We found that the risk factors of MAC was exactly like this patient. It was an older female patient, maybe small body surface area. And what we found is that with mitral annular calcification, we were still kind of able to overcome this. These are kind of two curves looking at repairability when you have disease or not. Sometimes you have to be a little bit creative. So we published this paper a few years ago because, believe it or not, one way that we can get sutures in the mitral valve annulus with the calcium is actually to put sutures from the outside of the heart in. So this is the mitral valve, and if you have calcium in this part of the valve, we actually will open the interatrial septum, put sutures from the right atrium across the left atrium to try to make it seal. If you have calcium towards the lateral commissure of the mitral valve, we actually will mobilize the space between the mitral and the aorta, and then put stitches on the left atrial roof. And we actually published this. We have a fair number of patients of this. With this patient and others, we'll actually, we can seat the valve. So our normal valve suture is a V7 needle, 27 millimeters. So if your calcium is 27 millimeters in height, you can actually get around this suture. You can't do that with this calcium in this patient. So we use the largest needle on the table. It's MH needle, it's 37 millimeters. So you can actually get around maybe 3.5, 4 centimeters of calcium. Once you seat the valve, if you can imagine, you're trying to seat a polyester prosthesis against something rigid. It may not be watertight. So what we do is actually we do a modified pericardial skirt. So this is actually a case that we actually did 2 in the last month, where we take this tissue valve, this is a pig valve, and we sew this skirt of pericardium on the back. So we have a surgical fellow who's learning mitral valve surgery from the University of British Columbia. So while I was doing the case, I gave him these 2 things and I asked him to sew it together. And then basically with the patient open, we we'll then pass our valve sutures across the mitral annulus into the sewing ring of the valve. And then at the end, you have the skirt that we then run and then close against the left atrium. So that's one way that we can actually deal with mitral annular calcification, get a patient out with a well-seated prosthesis without any regurgitation back into the LA. Case number 2 is entirely different. This was a patient that I did a couple of years ago, but I had the benefit of having the slides already edited. So I used this for the talk today. It's a 20-year-old female, basically a heart murmur, diagnosed since she was a baby, developed a class 2, class 3 heart failure, and you can see basically a severe mitral valve regurgitation and a bit tachycardic because she's a bit young. So what we do here is that we have a thoracotomy incision. We use a 30-degree thoracoscope. You can see there I applied a cross clamp on the aorta and I put a cardioplegia down the aortic root. This is actually a Prolian suture that we put in the left atrium. It does nothing but allows me to see. And then we zoom in with this camera and then we put these annular stitches in the mitral annulus, making sure that we put them in the white. Basically, we don't want to get into the electrical system. We don't want to get into the arteries. And we want to get it all the way around the annulus so that you can provide some support of the valve. Basically, one way that we can check to see if we're in the right place is that I grab the leaflet, and you have to take a nice strong Canadian bite so that if you bite at it and it's weak, you can actually cause perforations in the leaflet. So you have to grab it solidly, and then you pull it to the center of the valve, and then you just look to see where the hinge point is. And then if you can see the hinge point, then you know where to put the suture. You put sutures all around. We use a Medtronic future band as our annuloplasty system, and I'm sizing it there now. That's a 32 size. We're basically putting it in so it can cover the anterior leaflet. We've dropped in the future band, and now we're tying it with a Cournot system. And then the way we check it is we inject fluid across the mitral valve, following the path of blood, and we check to see how it looks. Now, this is not systolic pressure. There's diastolic pressure. We actually published a paper where we actually measure the pressures in the ventricle, but it gives you an idea of how the valve will look once you're off the heart-lung machine. So what I do here is we take an ink pen and we basically mark the free edge. And we want to know, once we suck out all the fluid, are the two leaflets just touching? Like, i.e., is the height of coaptation very, very short? Or is there a lot of leaflet underneath the ink marking, implying that there's a very good closure line? So that's one thing that we kind of look at. Now here, I didn't like it immediately. So I'll end up grabbing it and adding this extra suture to kind of reinforce the closure line, and using these long instruments. Everything's a little bit slower when you use these long instruments, but you want to make sure that they're precise. And when you come at the valve, you're much more lateral than you would be if you had a sternotomy. It's a white suture. This is a Gore-Tex suture, so the same stuff that's used in your winter coats, but this is a sterile version, very strong material that we use. And I grabbed part of the leaflet. We name it 1, 2, and 3 as we go from left to right. So that's A3, anterior leaflet 3, and then I'm going to grab the posterior leaflet, P3, and then you'll see me trying to pull it all together, and then we'll tie that suture. And you can't reach it with your finger, obviously it's too far, so you use what's called a knot pusher. And then and then this is the final saline test. So we always joke that we always have to record it, so we can always show the lawyers that at least we paid attention to this thing, right? But yeah, that's a good height of coaptation. I'm pushing here as well, and I'm really happy with that closure line. It's a nice smile of the mitral valve, so that's something that works out quite well. So this is kind of the incision. So basically, you kind of make a submammary incision in a female that's actually hidden by the breast. We have a camera port. This is the cross clamp that goes across the ascending aorta. We used to put a neckline. Actually, in the last 2 years, I've gone away from that because it's one extra cut in the neck. So in fact, we moved away to do even less invasive. What are the outcomes? So I promised you I wouldn't have a lot of day. I'm going to have 2 slides here. And I kind of stole this idea, like Talal will know this, Dr. Al-Atassi will know this, because Tommy Mihalovich, who is the CEO of Cleveland Clinic, will have just basically a slide with just one number. So basically 98 is kind of our percentile rank within the Society of Thoracic Surgeons. So we look at our mitral valve repair rate, we're 98th percentile. We look at our mortality for a mitral valve repair plus coronary bypass catheting, we're 98th centile out of the 1,100 STS contributing hospitals. I thought about not including the next slide, but if we look at our minimally invasive surgical patients that have had degenerative disease coming into the OR, this is our operative mortality. So in concluding thoughts, very thankful to be here. Apologize again for being late to the party in terms of saying slides. It's very critical that we have very good heart teams where we can talk about ways that we can manage patients, both with medical therapy or with catheter-based therapy. And of course, there is some surgical expertise in the building. Thanks so much for listening.
Thank you so much, Dr. Chan. Are there any questions?
Yeah, a question in regards to the repair of a mitral valve. When do you determine that it's time to repair the repaired valve? As far as the statistics is concerned, do you have any data on that?
Yeah, so the second slide where we had the 2020 AHA guidelines, and they mirror the European guidelines, is that when you have severe symptomatic mitral valve regurgitation, you should go for some type of intervention. Now, not necessarily surgery, because there's some types of mitral valve regurgitation where you can be managed with a catheter-based approach. But where it gets to be a little bit more gray is stage C disease, where you have severe regurgitation on echo, but you feel fine, so you're asymptomatic. It's, if you look at the guidelines, there's kind of a table where you go down, and it's a bit tricky because it comes down to two things. It comes down to where you're referred. So the place that you're referred to has to have a repair rate of over 90-95%. There's some chamber measurements where they want to make sure that your heart function is still pretty good. So they don't want your heart to be too big, and they want your lung pressure to be too high. But fundamentally, it's always a bit tricky because what determines how long and how well we live is the strength of our left ventricle. So the mitral valve is the back door of the heart. So when the heart squeezes, it'll always look normal with severe mitral valve regurgitation because the back door will just open. So the question is that, well, how long can you wait before you incur some damage in the left ventricle? Because once you start damaging the left ventricle, what we do know is that even when we fix it, not all of the sins may be forgiven. And then you start having to see how far afield you can get with medical therapy. If you decide to go for mitral intervention a little bit late. So we're still getting information about that.
The last question in regards to the electrical conduction around the mitral valve. Do you have any statistic on the correlation between any future issue with the circuitry when you do a valve repair, normally that exercise?
Oh, you mean about the heart rhythm?
Yeah, PVCs or any rhythm.
Oh, that's a tough question. The heart rhythm is the hardest piece, right? So the thing about the valve is that it's very mechanical, but the electrical system, without over speaking in some ways, because I'm not an expert in that field, but there are cellular changes that occur in the atrium that portend different types of arrhythmias. And the hard part about arrhythmia surgery is that we only have really one play. We take a probe, it's either radio frequency or cryothermy, like argon, like minus 170 degrees Celsius, and we draw lines on the heart. And our thought is that if you draw these lines on the heart will respond by making scar tissue or fibroblasts, and the scar tissue will act as insulation and prevent propagation of arrhythmias. That's our only play for arrhythmia surgery, not to knock arrhythmia surgeons. But it's a bit tricky because, if you want to make a door shut, right, by fixing a door frame, door hinge, it's a little bit easier to kind of gauge. But if you want to address a rhythm issue, you're talking about in part some change at the cellular level, and in 2025 it's still elusive.
Thank you. Are there any other questions? I think we have time for one more.
I was wondering, in your second case patient that you were performing 20 years old, would you be doing on Hannah, your first patient with the 84?
I'm sorry, couldn't hear that last piece.
I'm just swapping the age.
Yeah.
Suppose the 84 Hannah,
84
years old, had the same problem as your second case.
I see.
Which performed the same.
Yeah, so I'm trying to answer in a precise way. I guess your question is like age is not an exclusion, but one thing that we do look at is that in order to do conventional heart surgery, we got to get you on a heart-lung machine. So we need to get access to a major artery. So when we do minimally invasive surgery, one thing I didn't show is that we actually have to open up the right groin and we have to cannulate the right femoral artery, and then you have a catheter that goes there. So if you have disease or calcium of the descending thoracic aorta or femoral arteries, that's kind of a non-starter. So as you get a little bit older, especially with mitral aortic calcification, probably other stuff's a little bit calcified too. So usually that's the biggest thing, because if you have a calcified aorta or femoral artery, you actually have a higher stroke risk when we do peripheral cannulation. So at the end of it, I don't discriminate on age. I kind of discriminate more on size, to be honest with you, for a variety of reasons, because it's harder to get single lung ventilation if you're a little more stocky. But age in and of itself is not a exclusion criteria for sided surgery. Thanks for listening. Yeah.
Yeah.
Okay, so the next step is we're going to have a 20-minute break for dinner, and we will reconvene here back at 5:20. So please get your questions ready for the panel discussion, which will be after dinner. And we do have a couple of more prizes to announce. So the puzzle, we have Diane Barrett. And for Hartopoly, it's Karen M. Okay, we'll draw it before the discussion. So we'll see you back here at 5:20. Have a look at the booths and 5:50, sorry. And we'll see you back here then for the panel discussion. Okay, so I hope everybody has lots of questions ready for our panel. This is the last component of the evening, and most of the participants you have already met through the discussions earlier today. However, I wanted to bring a warm welcome and introduction to our patient partner, Hannah. Hannah was the patient that was screened at the mobile screening program and subsequently found to have severe aortic stenosis and was referred to the TAVI program and had a successful TAVI. So thank you so much, Hannah, for joining us today. We also have Dr. Al-Atassi again, cardiac surgeon, and Samantha Kolupanowicz. Cindy Cross, who is the advanced practice nurse for the Center for Valvular Heart Disease. Sandra Wong, who runs the mobile screening program. Douaa Swar, who is another sonographer. And Elizabeth Murray, who is our TAVI coordinator. And Dr. Messika-Zeitoun. He's in the crowd.
I thought you forgot me.
So does anybody have any questions for our panel?
Sorry.
About 5 years ago, I was diagnosed with a leaky heart valve. And my doctor said, and the cardiologist said, well, we won't do anything with it now. We'll just wait and see. I'm still waiting to see.
Hello? Yeah. I think I showed it one slide earlier about this whole risk benefit.
Yes, I was looking at it very closely.
Yeah, and then the indications, although, I don't know the exact numbers in your case and what the images look like in terms of the severity and all that. I think there are two big concepts to think about. One is, do you have an indication for a procedure at the moment or not? And the second is the risk benefit. And we always have to weigh that in a balance. So there's the risk of procedure, and there's the risk if we do nothing. Typically, leaky valves are slightly better tolerated than blocked valves. It does not mean that leaving leaky valves when there is an indication for too long will not damage the heart and weaken the heart. But the essential thing here is that there is an indication to intervene. And usually when it meets that indication, it means that the risk of leaving it now is higher than the risk of intervention. So these are the kind of considerations that your doctor is probably thinking about. Now, that being said, Dr. Messika-Zeitoun has also said that occasionally what we're seeing, and we're trying, through this day, but also education to, peripheral colleagues who may not be involved in these procedures on a daily basis, that, it is essential when there is an indication, or if there are any questions, that they do send the patients and referral to us and our team so that we can make that assessment. But that may be why you haven't still gotten the procedure or may not need the procedure at this point in time.
Well, I'll probably find out what, probably in a few months. I usually see him towards the end of the year. So I'll be seeing my specialist at that time. So we'll see what he says, see what I said at that time.
Thanks.
Thank you very much for your help. Thank you.
And just for your case, we don't know about the severity of the leakage. And Dr. Al-Atassi and the others clearly mentioned that we do intervention only when the valve is severely leaking. So if it's not your case, you don't need any intervention.
Hi, I have a question for Sandra Wong. I was just wondering about the mobile screening program. Is it possible for the city of Ottawa to give you a van or something that you could take to places instead of carrying stuff in the cars or 1 or 2 cars, whatever?
Yeah, I mean, that is the ideal. And our goal in our project as the Center for Valvular Heart Disease, as well as the Heart Institute, is that we do want to get a coach bus that would fit our needs. It's an ongoing project. At the meantime, we use our current vehicles to get around the city.
But we have a Guinea, how do you say that? The pig bank when you put coins. You have one at the exit. So if you want to give money, no, any funding is good. You can.
City of Ottawa.
Oh. City of Ottawa. We reached out to them at the beginning. It was very hard. We are working with the foundation to raise money. We are almost there to get the vehicle, but there is a lot of cost associated to that. I think Sandra didn't mention that, but everything that we do is at no cost for HIP. It's only on research money, and no participants is charged. So everything is paid on our research grant. So we need the transportation, we need to pay nurses, sonographers, the kids. So, but we need to do some fundraising. The goal is after that to demonstrate to Ontario Health that we are cost effective. And if we are, I think we can get money from the City of Ottawa, Ontario Health. But before you show that, I'm very pessimistic that any public system will give us any money.
Congratulate Dr. Messika for declaring February 22nd as the HBD Awareness Day. So congratulations to all of you, actually. Thank you. Thank you so much.
We have 2 questions from the participant online. First, maybe directed to Talal. Are we doing TAVI procedure for patients with severe aortic regurgitation? And Omar. Sorry.
So it's a great question. The initial TAVI experience was started in patients with aortic stenosis and calcific degeneration. And the reason for that is the initial valves that were made need some friction element to keep it in place. Unlike surgical valves that you suture in place, these are not sutured. So they rely either on friction or the outward force of the balloon inflating the valve, and sometimes the radial force outwards of some of the other valves as well, to stay in place. In regurgitation, if there's a little bit of calcium, we have done some mixed valves, so when they're leaky and stenotic or blocked, We have also done some pure aortic insufficiency or regurgitation patients, but this falls outside right now the indications or the sort of what the companies tell us are the instructions for use. Those are patients are usually not surgical candidates, and it's not safe to do surgery because surgery usually is the first line of therapy for aortic regurgitation at this point in time. However, there are some newer valves on the horizon which have been FDA approved and recently Health Canada approved that are dedicated for aortic regurgitation and leaky valves that have zero calcium. They have a different mechanism and little feelers and clips basically that keep it in place. We are actually, Omar, great, he just joined because we are right now speaking to the company to basically begin using it here in Canada, and here at the Ottawa Heart Institute would be sort of the first. It has been used, and I know colleagues where I trained in the States for fellowship have already used it quite a bit, but Health Canada was a little bit later in approving that. They wanted to make sure that they're safe before being approved here. So they're coming, stay tuned.
Hopefully soon. So they said 2025 we should have access. So hopefully the first half of the year we can start doing some cases.
What is there any specific cause for calcification?
Cost, you mean as in risk? Oh, cause. So we understand some of these mechanisms, not fully, but we know that the same risk factors that cause calcification of tubes and arteries, coronary arteries, tend to cause calcification in the aortic valve, diabetes, hypertension, cholesterol, all these things. As I said in my presentation, radiation to the chest can sometimes cause calcification. And generally any moving part, this is why we get arthritis of hips and knees, and there's a wear and tear. And similar to, my analogy when I speak to patients about putting in TAVI, and occasionally if you can buy some time and the patient is not symptomatic and there's no indication, that goes back to your question. So especially if it's a replacement, it's like winter tires. The moment you put the valve in, the wear and tear starts. So think about it. If your tire still has a little bit before it's completely worn out, occasionally we say, let's wait a little bit because the moment I put a new valve, it's going to start the wear and tear, which means if you're young enough, you're going to need one other procedure in the future. So occasionally we delay, not because we want to delay, but you may not be symptomatic, there's no indication, and there's actually benefit of using your native valve to sort of until it's completely worn out before we replace it, because that valve will calcify with time and degenerate with time as well. It's a moving part, so there's a wear and tear on it as well.
And that are risk factors, but we don't have any medication to prevent that. So we cannot either slow down or take the calcium away. When it's done, it's done.
Say there is no human Drano that can dissolve it.
There was one question from the audience, just as, from online. They said, when do we have the mitral valve replacement? Omar, you can give us a date. I think Marino mentioned that. We are doing the first mitral valve replacement.
March 26th. We have a
So, and we will post that on social media.
We I think began two, like a replacement. We've done 2 and more coming, right? In terms of like transcatheter. Mitral, okay. Yeah, we did 10 lines, yeah. Yeah.
And so I have the multiple question if possible. One. I'm tall guy, 2 is fine. Okay, for Sam, I need to know when you do the echocardiography, do you do the ejection rate as well for the heart?
Making sure that the heart is pumping well and that kind of thing. So if someone comes in for a different issue and then we find a problem with the ejection fraction, then more testing will be done, because from echo we can't tell why that would be happening, but we can tell if there's any damage to the muscle.
Because I was told that with the ejection fraction, it's a very subjective way of looking at the numbers eventually. I don't know if AI will help down the road with all these things as we progress in the calculation scheme of things and modeling.
Yeah, for sure. I'm certain that that's probably one area that's maybe going to be beneficial, but that's probably a long time off, but
No, there is always the one company which has a FDA clearance for automatic interpretation of echo. I haven't tested it, but it's here.
So I'm fired next week.
We're still in your arm before we get a robot.
So, Sandra, how is it going to be possible to have your screening program outside of Ottawa? Is there a strategy in place so that there's communication? So let's say a community van would and people in it would come into a certain place in Ottawa, or would you be willing to go out to a community in outside of Ottawa?
Great question. So typically what we do is I liaise with whoever's interested, whether it's rural or in the city. And if it is rural, that's no problem. We will go out of the city to do that. It just depends on where it is. If it is a very far distance, typically our staff is doing an 8-hour shift. So we also include drive time in there. So really gone into, if it's further than an hour and a half one way in terms of driving, we will stay a night over at that location and actually make it like a multiple day clinic and make it kind of beneficial for that community. So it just depends on the needs, and we've done the overnights for some of the Indigenous reserves that we've been to that have been 2 to 3 hours outside of Ottawa.
So is there a strategy in place then to tackle the whole province? And for example, is Toronto doing the same kind of thing, their Heart Institute?
It's a great question. From our knowledge, it really is within our area. It's doing kind of screening program. Our priority is to expand. First, our priority will be the Champlain region, which is actually the current area that the Heart Institute serves. So that's within an hour and a half drive. And if it is outside of that time frame, then we will assess sort of case to case basis, and then kind of use different connections and data just to kind of see what those needs are and grow from there. So the only exceptions that we've been outside of Ottawa for that distance is with Indigenous reserves.
Okay, thank you.
Sandra, maybe you can mention that we are trying to partner also with a family health team, and especially in further area like Cornwall. So we're trying to go outside. It's a lot of logistics, but we try to do it. Who is next?
There's a question for Hannah. Hannah, can you speak a little bit about your experience with our programs?
Went to the screening clinic, which was in my seniors co-op, just because I thought, well, it wouldn't hurt to find out if there's something wrong with my heart. I never had heart problems, and I really didn't have symptoms. At that point, I was 85, and I was getting older, and I didn't have as much strength. But then I went, and Sandra and the fellow with her doing the echogram, they were so good. And I realized I had moderate stenosis of my aortic valve. But she immediately told me that you will get consultation with a cardiologist. And that relieved me, knowing that, okay, we're going to take care of this. Well, and just exactly as she said, she told me it'll take 4 months. And in 4 months, I got the appointment. And it was Dr. Messika and Dr. Douaa that saw me. And one of the things I really want to say is, both my daughter came with me, Elaine, and Elaine and I were both so impressed isn't the right word. They both, Dr. Douaa saw me first, then Dr. Messika came in, and the nurses as well. I can't remember them all that I met that day. They were so kind. And the thing too that so impressed me, these busy people, they spent an hour, Dr. Douaa and Dr. Messika spent a full hour with me. And they went through it so thoroughly and so carefully and so graciously that I felt in complete confidence that I was in good hands and they were going to do a good job, which they did. And I was just very, very grateful. And I'm doing fine. I couldn't believe the difference. By the time I saw them, before I saw them, I literally could hardly walk down the hall. I'm used to doing the whole, I live in a 3-story complex, and so I would do the whole thing on the stairs and all of that. I could hardly walk down to the elevator without huffing and puffing. And I just didn't have the strength, and my brain wasn't functioning that well. And now I can do the whole thing. I'm now getting up to 1.5 kilometers at least a day, started my exercises, and my brain is working so. Dr. Messika warned me I'd be much better than normal.
Thank you very much. Thank you for your comment. I think the full spirit of the program is to be preventative. What we want to avoid is patients having a not diagnosed, having symptoms, heart failure, being admitted, and have a worse outcome. So if we try pick up patient early, we can follow them and have a timely intervention, avoiding admission, especially when you see how packed are the hospital now, and do the timely intervention. And it's when you do that, it's when you have the better outcome.
I think you nailed it right there about we see in the news all the pressures that the different hospitals have. And I think, if we are ahead of the game and patients don't get sick enough, one, the procedure risk is better because going in without a weakened heart, you will do better. And two, I think the impact on the healthcare system will be better as well. So, yeah.
Okay. So is it okay? Can you understand? Okay. I hope you can be indulgent with my English because I'm not used to. So I heard last year I have 3 valves not working well with regurgitation. And I have the, I think the inside of your heart, they have the septum, have a hole. And they don't know what I had when I was young. It may be from when I came to birth few months after. It's not closed, have not closed, or they say it might be infectious. Donc, so I don't know what to do because the doctors doesn't seem to be worried, and it's a cardiologist, but don't worry, he's not in Ontario. So I'm feeling I'm 80 years old, and I would like to know what you think about that, what I can do.
So, and I'll let maybe also Omar comment on it. So I think, again, maybe the devil is a little bit in the details. And occasionally when we tell patients you have a bit of a leaky valve, you have a sticker put on your back right now, and also it becomes in your mind, right? You're thinking about it a lot. I think we probably sometimes have to be careful in the sense that we want you to be aware, but also aware that at times it is not severe enough and it's something to keep in mind, but maybe not to be too concerned about. So really, in this case, I don't know the numbers in your case, but
no, but he's taking his retirement, and I will be referred to someone else.
Yeah, I mean, we're happy. I think all cardiologists probably recognize I would say the indications when things get severe enough to require intervention. The hope is that when it reaches that point and you're feeling unwell or symptomatic, then you're referred to our program, and that we would be taking care of you. In terms of the hole in the septum of the heart, Assuming that's usually congenital, it's a hole that's present when the baby is in the womb, and then when the baby comes out, that closes just because of the nature of the oxygenation, and now they can use the lungs, so they don't need that hole. Occasionally, it doesn't close fully. The main implication, it doesn't usually cause a lot of problems. The only time when it could cause problems is if someone has a blood clot in their leg, because then it goes from the right side to the left side of the heart and could cause a stroke. So there are, again, sometimes indications for closing them. We don't routinely close every hole that we see on an echocardiogram. Actually, Omar can probably comment a little bit on that, since he's involved in plugging those holes when it is needed. So again, I think the big picture is not every leaky heart valve requires intervention. Occasionally also, we see patients who have one dominant valve problem that needs to be fixed, and other valves that may have a little bit of a leakage. And what we see is we fix the main problem and other valves improve, or we watch it, it doesn't improve, and then we just have to follow it when it becomes severe enough. Again, look at therapies that we can, offer at that point in time. Okay. I think I'll give Omar a few words.
But just to let you know, I had a clot in my legs a year ago, and I have to insist to pass exam to see a specialist, and it's quite hard sometimes.
But one also important comment is to trust your doctor. If he has all the elements in hand, including the echo report, your symptoms, and he thinks that you don't need an intervention, you can have a discussion with him again. But at the end, he is the one who knows when to refer you for an intervention, and you have to trust him.
Yeah, I agree with everything Dr. Al-Atassi and Dr. Messika-Zeitoun have said. The devil's in the details. We don't know everything about you, and we don't know everything that's on your echocardiogram. So some of these things may not ever need to be treated. And we see lots of echocardiograms with leaking valves and small holes that we just watch. They're scary words for sure. So maybe, I know, but sometimes 3 leaks may not amount to very much. And, I don't know all the details, but.
If they are severe, yes. But
yeah, if they're severe, sometimes it can, but if they're mild and moderate, it may not. And it goes back to what Dr. Al-Atassi said, once you put the tires on, you start getting wear and tear. So sometimes you don't need to do anything until they're causing a problem, or you think they're going to start causing a problem. So
90.
What's that?
Did 90 at 90 years old.
Yeah, so then you can keep going to 190.
Okay, thank you.
I'll ask a question from online, maybe for Cindy. How do we address people in our community with our MSP screening program if they don't have a family doctor?
Well, so if they don't have a family doctor, at the time if Sandra's diagnosed a problem, if they have like cholesterol problems or hypertension problems, at that time, if it's non-valvular, we recommend that a walk-in clinic that's close by. And unfortunately, we know nobody wants to do that, but that's a lot of, like we saw in the stats, only 4% didn't have a family doctor. And saying that 4%, some people have a family doctor but can't get in or don't regularly see them. So we're trying to set up our next step with the prevention team that's here to help cover those people that don't have a family doctor or haven't been diagnosed. So we're not putting the workload back on the family health teams. But right now, if there's no family doctor, unfortunately, the recommendation would be to see a walk-in clinic.
Hi, I'm a patient of the Heart Institute, and I had open heart surgery, elected to have a tissue valve. Edwards tissue valve was inserted. You brought up wear and tear, and this has always been on the back of my mind. If someone is like, let's say I'm out doing exercise, biking, cycling, snowshoeing, and my BPMs are up, so I'm working the heart valve. Is that part of the wear and tear you're talking about? Is that could that be a problem? Could I shorten the lifespan of that valve? If you know where I'm going?
No, I think the last thing I want to impart is the message that, don't enjoy life and exercise and do all these things. I would say there are some things that we understand in that process and a lot still that we do not understand. We also see a difference in every decade of life. So the younger you are, patients in their 50s, in their 60s, in their 70s, there's a different durability of those valves. So it is not just hemodynamics, although it plays a little bit of a role. I would not, so you can exercise all you want, but there is also sort of a chronic immune. I always joke and say it's your body chewing it up slowly. Again, it's the wear and tear of the calcium deposition, the degeneration of things moving. So there is some cellular changes that happen, some immunologic changes that impart these degeneration on the valves. And there's some hemodynamics, but we would never say, don't exercise. I think it's actually good for your heart to exercise. It makes your heart more efficient in its way of contracting. So I wouldn't worry from that point. I don't think you will have too much control on the way it will degenerate in a specific patient, as long as you have secondary prevention. So you're treating the risk factors properly, your diabetes, your hypertension, you're taking care of yourself. And obviously if you're exercising, so that's great. But every decade of life, and sometimes, we talk about these curves, so it's like a bell curve, and we look at, for someone, let's say at 70, and we look at data here at the Heart Institute, and in most places it's around 12, 13 years is when there's peak. That means half the patients by that time will have degeneration of the valve that may require an intervention, but the other half will last longer. And I've seen patients up to 20 years and nothing happened. Then there are patients who may be on dialysis, where again, there are things that happen biochemically that it eats up the valve or degenerates faster. So again, I go back to my car, when I service it, they tell me this winter tire is gonna last that long. And sometimes it does, sometimes it lasts longer, sometimes it lasts a little bit shorter. But we have an average sort of for a patient of a certain age. But certainly continue to enjoy life and exercise.
Yeah, and which I'm gonna do anyways, but I was just wondering, like, you get so many, it's like the Energizer Bunny, so many clicks and then it's done, sir. But, and the TAVR within the TAVR, because I was told, if I come in for another valve, like they could do another TAVI or TAVR procedure. How many of those can you do? Just curious. Like, is it like one, maybe two, and we can't do three? Is there a limit as to how many you can do?
So a few comments on that. The first is that when we started these procedures back in 2002, actually the early 2000s with the big trials, initially, because it's a new valve or new technology, you can't just say, let's just put it in everyone. You had to have, ethically, it would be only placed in patients who were inoperable. Those were patients probably, in their 90s at the time. I remember when I was in the States, we did on a patient who was a 104-year-old and did well. And so once we proved that in those patients who had no other options, like Dr. Messika-Zeitoun had said before, now have an option. Then we moved on to younger and younger patients as the iterations of the valves, of the procedures improved and became safer and safer. Now, the patients who were in their 90s, if they had 6 months or 3 months and we moved it to 2 or 3 years, that was a big success at the time. But most of them are not around with us anymore. As we move to younger and younger patients, now we have trials that will look at 10 years. And we have some data. I showed one slide where it was about 50 patients in each arm. So still small numbers at 10 years, but we are going to see more and more patients, which means we're going to see more and more of those procedures as they come back. I have published, we have one case report, again, when I was at the States, which was a valve, and the patient did well. But you start running into limitations. Real estate limitations. We cannot, at some point, it becomes too small of a valve for your own size and what you need. So that hole that becomes smaller, you put a valve that's appropriate size, hopefully the first time. You put a second valve, you can stretch things, we can do certain tricks to get the best opening possible for your size. Again, frame and door, we're always sizing things, and that's where the CT scan helps. But eventually you run out of real estate where you kind of still create some stenosis. You're leaving a little bit of blockage because you just can't put such a big valve. Similarly, the anatomy is important. You have structures around it that may limit what we're able to do the second time around, and it's all dependent on the CT scan. So sometimes we can do it, sometimes we can't. And there are many things procedurally that now are coming out that we're learning how to place the valve in certain orientations, certain procedures that may facilitate that second valve. So, hopefully we can learn a lot more. And when we see a lot more of those patients as they come back, hopefully not so soon, but, we will be offering these procedures. We don't know past the valve and valve. I think it's a bit too early.
So I think we have time for a few more questions.
Hi, everyone. I, as a result of attending one of the clinics, found out that I have a leaky valve. Otherwise, I never would have known. I didn't have any great symptoms or signs or anything. But my question is about medication. I just want a refresher on the value and the use of having blood thinners. And that's my question. So if someone could please just give me a refresher on the importance of and the use of blood thinners, please.
For a leaky valve. So the question is just, you have a leaky valve, you don't have arrhythmia, should you take a blood thinner?
So for a leaky valve, there isn't really a strong indication to be on a blood thinner, or really any indication that I know of to be on a blood thinner for a leaky valve alone. But as Dr. Labinaz was showing, sometimes when the valve leaks, it puts pressure on the top chamber of the heart, and that can cause arrhythmia. So an arrhythmia called atrial fibrillation. I'm not sure if that's the problem that you have, but that can increase your risk of having a stroke significantly. So often those two problems go together, but for a leaky valve alone, you wouldn't necessarily need a blood thinner.
The other thing, your heart sometimes is weaker. There's predisposition to more blood loss, so sometimes that could also, when the chambers is not moving a lot, there's stagnant areas, so that could be just another indication for blood loss.
Just for the leaky valve, no blood thinner.
With a tissue valve, I've been told that antibiotics for dental work are essential. But then I've also read that some places in Europe, they've started to abandon that. Any thoughts on that?
Yeah. So the current guidelines say that anybody that has a valve replacement or repair requires prophylactic antibiotics to prevent an infection on that new valve. So when you have dental work and you have any manipulation of the gums or risk of bleeding, any bacteria that's in the mouth can then travel to the heart and attach on that new valve. So we want to avoid that. What our recommendations are to all of our patients is to indeed take those prophylactic antibiotics, and that should be something that your surgeon or your cardiologist is reviewing with you.
To answer your question, it's recommendation in most countries except one, which is UK. They have dropped it. The level of evidence is relatively low. They have not seen an increase of endocarditis since they drop it, because you have bacteremia, so bacteria in the blood, even when you eat or you brush your teeth. That's a rationale for not doing that. So we do it in most countries. Maybe we're wrong, but it's the current recommendation is to take it.
And go ahead.
Sorry. Yes, I know that some dentists have stopped using antibiotics during surgery and dental work. Just to complement that.
In a patient with who had a valve intervention.
No, just in general. They used to give you antibiotics
yes,
all the time.
Yes, we were excessive before, but so the current recommendation is antibiotics before dental care only if you have a valve intervention, if you have, or if you had a prior infection.
So this is a question for you, actually. So today's presentation, maybe not the question area, was videoed. Will we all have access to the presentations today?
You've recorded. day.
Yeah.
Do this session as well. And so what we were going to do, you can always let us know, but we were going to give you an opportunity because you gave us your email on the registration to email it once it's finished through the teams.
Now, I didn't know that you had a presentation a year ago. Did you record that? And is it possible for people to see that?
It's a bit of a mishap on that day. It was supposed to be recorded and then it got choppy and they didn't get it. So we've been very diligent about asking things in the back room. Is it recorded? Is it recorded? And Sandra's recorded it as backup. So unfortunately, no.
Okay, thank you.
I have a question from the audience, online, virtually. For patients with aortic stenosis, does it make any difference if the patient has a bicuspid valve instead of a tricuspid valve?
So the short answer is yes, it does. You know, in terms of having stenosis or regurgitation, bicuspid valves tend to degenerate earlier, so they develop calcium and they become leaky, so to speak, sooner than tricuspid valves in most people. Bicuspid valves are also associated with other abnormalities like dilation of the ascending aorta, which is the big pipe that comes off the heart. So those are the things that we consider. And then in terms of intervening, most of the information that Dr. Al-Atassi passed along to you is based on tricuspid aortic valves. So patients with bicuspid aortic valves, though if they don't have an option for surgery, will often consider TAVI or transcatheter aortic valve replacement. But most of the literature that's out there is on the basis of treating tricuspid aortic valve disease. So we often refer those patients for surgery with Dr. Al-Atassi.
Any other question? I have one.
I add one, a couple actually things, you know, so it's true they come in earlier, the intervention, so we've adapted the skills and the procedure to accommodate for a higher calcium on the bicuspid valves. And so we have been doing TAVI procedures in some patients and really the anatomy and the amount of calcium, because a little bit of calcium is good to hold the valve. Too much calcium becomes a risk in terms of rupture and things like that and other complications. So the standard is still surgery, but this is timely because there will be a trial, in fact, now, multi-center international trial looking at bicuspid valves, you know, doing surgery versus TAVI and how will the patients fare. And that's, you know, we have some studies, but they're not as rigorous and randomized. This will be probably the biggest study that will come. It'll take a few years, but so you might be approached if you have a bicuspid valve at some point by a research nurse to ask you, would you want to be part of that study? So hopefully in 10 years, when we have this session again, we will have a great answer for you.
You already asked too.
I have a question for a mitral valve. I'm not sure who will be answering me on mitral valve. I think it's two parts. The first part is what determined the fact that you can go for a mitral clip versus an open heart surgery? I was shown that you have a graph that shows the combination is excellent. That means you have to do both anyway. When you do a valve repair, why we cannot do the mitral clip afterward as well?
So, you know, we could do I'll just say that, you know, it's usually initially one or the other. We don't do the clip during the surgery. There is the clip is basically, there was a surgical technique with sutures, which the clip imitates. And that's what we, you know, back in the days, we have a suture technique that imitates a clip and we put a ring. It's the Alfieri technique, it's called. And so the clip became a technique that we could do the same thing, but through the groin, although we don't put the ring in there. And so there are a variety of things like the aortic stenosis where we look at patients' suitability for surgery, risk factors, and things like that. And also anatomically, if the clip is feasible and we can decide. It doesn't mean that if you have a replacement, then you can't do a clip on a replaced valve, but you can do a TAVI valve within a surgically replaced valve. So it's called a valve in the mitral position. And then if you have certain types of surgical repairs, that may still be amenable to a clip in the future. Similarly, if you get a clip and that fails, if you're a surgical candidate, you may have the option. So you don't burn the bridge of doing surgery for replacement. you sometimes may burn the bridge of repairability because there's some scarring that happens from the clip. So it's a lot of thinking of the anatomy and we look at many factors.
Yeah, I don't have a lot to add from what Dr. Al-Atassi said, but it is a complex decision that's based on patient factors and anatomic factors. That's why a dozen of us sit in a room on Wednesday very early in the morning and look at things. In terms of doing a clip after a repair, it is doable, but it's often very difficult. So that's one of the factors that we would look at when we're reviewing these valves in our valve conference.
Okay, so last two questions, and then it will be time to further assess the information boost.
Yes, just one quick question. Is there any research being done on artificial hearts? I know it's a bit of a tangent, but I just hadn't heard anything since EVAD years ago, and I just wondered if there's any pursuit of that here.
I can answer because he's French. There is one, at least, company. Alain Carpentier is one of the main surgeons for mitral repair. He's from France, and he has developed a company doing a full artificial heart called Carmat. I think another company is working on that, but it's very, very preliminary. Maybe a solution would be a pig heart.
So in the States during fellowship at Cedars-Sinai, we did some total artificial hearts as well, surgical replacement. Again, it's very early in the sense that they're still associated with some complications, clotting, things like that. They're trying to get over, and there are a lot of factors still. It's on prime time, but it's still in the development. It has been, I guess, for some time.
The French one is fully tissue valve compared to the others, but it's very, very early. If I have to make a bet, I don't think the artificial heart will be a solution. I think animals.
So the gentleman at the back. Oh, okay. Go ahead. Go ahead, sir.
I think this program really has impressed with the presentation of the team of the screening, because what I see is that at least 30 or 40%, 30 or 40% that you have sorted out are non-valvular problem, but risk to cardiovascular. I think you perform an excellent education program with this screening. So congratulations. Let me ask you, Sandra, if you have $1,000 or $2,000, how would you add to your toolkit?
A new car.
I mean, there's many things that I think our program wants to grow. Like, yeah, I mean, of course, if we're looking at a growing thank you. If it's a growing program, it requires a lot of staff. It requires a lot of supplies. And as I mentioned earlier in my presentation, it really is an elaborate teamwork from the research side, the clinical side, and all of that, as you may know, takes funding. And we were very graciously given funding at the beginning to build our program. But as we look to expand and grow even more long term, that is something that we do need in terms of funding. And as I mentioned, increasing capacity in terms of team and staff is critical. And also, ideally, is to also have all the supplies and the bus to kind of get us going. So if you're interested, we'd be happy to take any funding you want to give us. I'm not explicitly promoting that, of course.
Just to clarify, don't give it to Sandra. You go to the University of Ottawa Heart Foundation and you write mobile screening program. We don't accept check.
Appreciate it, Benny.
There was one more question in the back.
So am I the last one?
I think so.
Anyway, I just wanted to express, no questions for you, just wanted to express heartfelt gratitude to the Ottawa Heart Institute, the staff, Dr. Messika, and everyone, because you folks, you are a world-class institution and I think I speak for many people here. I've been a patient alumni since 2017, 7 years, going great. Heart is filled with gratitude for you folks. And every time, every year, or every time I come to the Ottawa Heart Institute, all I get is good care, empathy, and very well looked after. So I'd like to, congratulate all of you. And in terms of, your mobile screening program, I'm sure you're working with the local rural municipalities. Maybe need to get in touch with the mayors, local mayors, because I'm sure people out there, they're looking for this kind of, help and service. So I think there are enough people in this room and online. I don't know how many. Maybe we can all band together and, like this gentleman said, willing to contribute to get that van rolling, and proudly that says, Ottawa Heart Institute and Mobility Screening Program. So thank you. Thank you very much.
Not to get overly political, but there is an election next week. So that's a really good mechanism to try to divert dollars back into the healthcare system. So I want to thank everyone for attending Heart Valve Disease Awareness Day today, both online and in person. Thank you so much for taking the time to be here. We hope that you've enjoyed all the presentations from our really well-established speakers. So a big thank you to everyone who sat on our panel, our sponsors Abbott and Edwards, who helped to make this day possible. Our patient partner, Hannah, thank you so much for being here and sharing your experience and story with us. IT, communications, and the facility staff at the Heart Institute were a big part of making today happen as well. So thank you so much to everybody. Please complete our short survey on the way out, and don't hesitate to approach anybody with questions. Heart Valve Voice Canada is here as well, and they're a patient advocacy group helping to promote today and valve disease awareness. So thank you so much. Have a great evening.
Here, but sometimes I'm skating quicker, sometimes I'm skating quicker, to get this there. So,